That we are learning.
Yeah. Namaskar and good evening, everyone. I welcome you all for today's webinar on Onco-Vigyan 2025. And the theme of the conference is Science and AI in Oncology. With great pleasure, I would like to invite Dr. Mukesh Bansal, who is Senior Consultant Medical Oncology and Hematology at Alchemist Hospital, Panchkula, for the welcome and introductory note and to set the ball rolling. Over to you, sir.
Namaskar. Good evening, everyone. I warmly welcome you all in our second edition of Oncology Updates. So this year, as the ma'am said, the theme is Onco-Vigyan, Science and AI in Oncology. As we know, in last few years, artificial intelligence is coming in almost every field. And now it is the time that it has come in medical science also, especially in oncology. Right from diagnostics and treatment choices, we are being read with new information of artificial intelligence. So I again welcome you all in which I believe will be a very interesting discussion. This year we have kept the agenda as very short and crisp, focusing on the latest updates, especially as the ESPO 2025 has taken place around 2 to 3 weeks back. So we have included the latest ESPO 2025 updates also. So I think all the faculty will actively participate and we will have a great discussion. So for the first session, I welcome Dr. Rajiv Tangri sir. Sir needs no introduction. He is an authority in histopathology and cytopathology, currently working as Technical Director, Histopathology and Cytopathology, Dr. Lal Path Labs, Delhi. Over to you, sir.
Good evening, and thank you, Dr. Bansal, for the warm introduction. And thank you very much for giving me this opportunity to present at this great forum. And as you said, artificial intelligence has greatly invaded into every field of life, and especially the medical sciences and in oncology. So I'll be covering the topic of emerging role of artificial intelligence in oncopathology. So if I have the sharing rights, I'll start the presentation right away.
Yes, sir. You can share
Yeah,
from your side.
I have the sharing rights. Yes. Is my screen visible?
Yes, sir. It is visible. Just make it full screen, sir.
Yeah, I'm doing it. Yeah. Is it
Yeah,
okay?
that's okay.
Yeah, thank you. Yeah. So, as I said, my topic today is emerging role of artificial intelligence in oncopathology, and I'll restrict myself to pathology part, and I'm sure the speakers later on will cover the treatment part also and role of AI in oncology on the treatment side also. So, as I said, artificial intelligence has significantly changed our everyday life, and we are all aware of Alexa, the drones, the smart watches, even the simple, I mean, Google Maps that we use on day-to-day basis. They use a lot of artificial intelligence to help us choose the best path to our home and to work every day. Of course, medical field or healthcare is not far behind, and a lot of artificial intelligence has come into medical field also. I mean, virtual nursing assistants and medical image analysis, AI-assisted medical diagnosis, robotic surgeries, and AI-assisted radiology and radio diagnosis. All these are into the field, and now AI-assisted pathology or oncopathology is also now coming up. Of course, we should not forget about the downsides of AI, though I'm not here to discuss more into the downsides. I'll be discussing only the positive sides of AI in pathology. But of course, we should not forget about the dangers about loss of human jobs, AI terrorism, AI-based bias, autonomous weapons, and everything. And it's invading our privacy day in and day out. You see, you open your Facebook, and if you have searched for something the previous day or the same day in the morning, you would appear. The suggestions would appear into your Facebook or your other social media account the same day. That's a serious privacy of a serious invasion of our privacy. But let's forget about that for the time being and discuss more about the positive uses of AI. So AI is said to be the third revolution in pathology. I would not go into the details of this chart, but the first revolution was about immunohistochemistry that came up in about 30 years back. And the second revolution was the genomics and proteomics, that is the molecular diagnostics that came into being. And now the third revolution is artificial intelligence. Now this revolution was triggered when Philips was the first, company that was approved for a digital pathology whole slide scanning solution. Its IntelliSite was approved by FDA for use in scanning of slides. That was the first, step in usage of AI in pathology, and it has developed ever since then. In last five years or so, it has significantly developed. I'll show how it is being used today in pathology. Now, why do we need digital pathology and artificial intelligence in pathology? Now, this is a chart which shows that the number of pathologists are scarce throughout the world. Except for few countries like US, Canada, and maybe Australia. Everywhere there is scarcity of pathologists. And in India, we are in the orange zone, which means that only around 10 to 19 pathologists per million of population. Now, there is increasing pressure to move faster, to deliver reports more efficiently. So lab needs to find way not only to assist the pathologist, but also to be future ready. So probably AI assist and digital pathology is the answer to it. Now, this is a basic digital pathology, how the digital pathology laboratory looks like. It includes a hardware, which is a slide scanner. A large storage is required where all the images are stored. It's not like the glass storage. We don't store the slides in digital pathology, but the images are stored. So large amount of storage is required. And then there is an image management system, which replaces the microscope, wherein we can view the images. And this is how a digital pathology image typically looks like. You can toggle with this image, you can zoom in, zoom out, and do whatever you want to do. The way you work on a microscope, you can work on a computer screen and play with these images and diagnose the cases on the computer screens. Now, what is the utility of digital pathology? So, of course, the remote reporting is one of them. You can take second opinions from anyone, anywhere in the country, or internationally. You don't have to send the slides and blocks for it. This archival and storage of and retrieval of cases is very easy. You don't need large amount of space to store the blocks and store the slides. And then there is there is a fear of losing them out. Blocks being eaten away by the rodents, then the slides being broken. So all these are removed by digital pathology. And on the top of it is ability to use all these images for artificial intelligence-based softwares. Now, there are a lot of applications of artificial intelligence in clinical practice in histopathology. So there are a lot of softwares are available which help us in tumor detection. We will see it a little more in later slides. It also helps us in classification of tumors very accurately. It helps us in cell segregation in quantification of cells, in grading of tumors, in identification of lymph node metastasis. I mean, there may be micrometastases which are undetected by human eye, but artificial intelligence-based software helps us in identifying those very easily. Detection of metastasis, counting of metastasis, detection of perineural invasion, all these becomes very easy when we use AI-based softwares. The adoption, I mean, of course, requires a lot of calibration and validation, and College of American Pathologists has laid down certain guidelines which every laboratory must follow, that is planning to adopt digital pathology and artificial intelligence into their routine practice. Now, when I talked about my laboratory, that is Dr. Lal Path Labs, so we started our journey in digital pathology and artificial intelligence way back in 2018 when we acquired the first whole slide scanner. And after that, the journey has been upward. We gradually validated that scanner. We started using artificial intelligence in 2019, December 2019, when we validated breast biomarkers, that is ER/PR, HER2/neu, and Ki-67 reporting using AI-based softwares. And presently, 100% of our ER/PR, HER2, and Ki-67 of breast cancer, they are being reported using AI softwares. Later on, in the subsequent years, we also acquired another software from IBEX, which is a prostate biopsy software. I'll talk about it a little more details later on, wherein the software helps us in accurately identifying the prostatic tumor, accurate classification of the prostatic tumor, accurate grading of the prostatic tumors, and also identifying perineural invasion and prostatic in situ carcinomas. So presently, if we see today in May 2025, we have reported more than 75,000 of cases using digital pathology. More than 10,000 of cases of breast carcinoma have been reported using AI softwares, and more than 15% of the cases of prostate biopsies have been reported using the prostate AI software. Now, this is how the breast software looks like. I mean, as I said, you have to scan the slide first, and the whole slide image is created. Now, this is a slide of an ER. The slide is stained as usual. However, when we open the AI software, we have to select the tumor areas like we have done here using the red outlines. And when we submit this to the software will give us the accurate percentage of all the positive cells. It will count all the cells in the selected areas, and it will also count the percent positivity in those areas. So the results of ER and PR are very, very accurate. Similarly, this is HER2. HER2 is a membrane staining. So again, we have to select the areas, and it will count the positive cells in that area. So now, like in this case, a software has called it as 3+, which is very accurate identification. Now, what we have observed over last 5 years, ever since we have used this software to report our ER/PR and HER2/neu, that the HER2/neu equivocal reporting has significantly reduced. And we actually presented our large study in one of the conferences, international conferences recently, wherein we found that AI tools helped us in reducing our HER2 equivocal cases from 14.9% annual incidence in 2019 to less than 8% annually. Now, this is a very significant cost impact to the patient because all the equivocals need to undergo HER2 testing by FISH. So this cost impact is directly to the patient. Plus, there is a lot of time saving because all those equivocal cases don't need to undergo now HER2 FISH testing because they are accurately segregated into either 1+ or 3+ by the AI software. So this is one of the big advantages. When I talk about our other software, which is the IBEX software, which we are using for carcinoma prostate. Now, carcinoma prostate, is one of the very common cancers in men, and as we know, there are a lot of requirements from CAP and ESCO before treatment of acinar adenocarcinoma prostate cases. We need to give the Gleason pattern of and Gleason grading, Gleason grade group very accurately. Tumor quantification needs to be given, perineural invasion, extraprostatic extension, and high-grade pin. All these need to be included in the report, and these have to be very accurate. Now, the problem is that there is subjectivity of reporting, especially when we talk about Gleason pattern and grading. There is some subjectivity while reporting pattern 3 and pattern 4. I mean, there may be interpersonal variability in reporting between pattern 3 and pattern 4. And when we talk about the grade grouping, I mean, the quantification is also important, and that there again, there is a variability. Somebody may call the same tumor as 4+3, while another pathologist may call it as 3+4. The grade group will be different. I mean, for 3+4, it will be grade group 2, and for 4+3, it will be grade group 3. So the treatment will differ. So all this can be solved by the AI-based softwares. Plus, there are a large number of slides in prostatic biopsies, as we all know, which need a lot of time for pathologists to screen those slides. So that is also removed when we use the AI softwares to screen those slides. So, as I said, we were the first one in the country to deploy AI-powered cancer diagnostic in prostate carcinoma. And this we started using in end of 2021 and early 2022. As I said, we are using the IBEX software, wherein we have to log in into the software. And once we log into the software, the tumor is highlighted by the heat maps. As you can see on the left-hand side here, this is a prostate biopsy, and the tumor is highlighted by the heat maps. The red area indicates the high probability of tumor. Similarly, there will be other areas which will be highlighted. The Gleason grading will also be highlighted. Sorry, this is not a correct image, but then the tumor will also be highlighted by the similar red areas. And we give a report in all such cases. The reporting is given along with the heat maps of the slides of the images which are available from the AI software. All these are included. So this is a prototype report of prostate biopsy wherein all these heat map images are included. Whenever IHC is required to confirm the diagnosis, we also perform the IHC in such cases, and that also is included. So this is one case that I would like to highlight here. So this was a case, an interesting case where there were 12 slides of a prostate biopsy, and AI tool said that out of 12, 11 slides were benign. Only one slide, it called it as indeterminate. It was not sure whether it is carcinoma or not. But it highlighted some areas. This is the heat map that is highlighted here. You can see that there is a very small focus, which is highlighted as yellow to orange here. Rest everything is clear. When we removed this heat map, we saw that there were small glands here. Now these glands, could have been passed on as benign if this was not highlighted by the AI software. So since it was highlighted, we did perform IHC to confirm whether these are malignant or benign, and these actually turned out to be malignant. These glands are positive for a marker and negative for P63. So actually AI in this case helped us in identifying SNR adenocarcinoma Gleason 3+3, 6. Which involved only 1 out of 12 cores and with tumor quantitation of 3.6% in the involved core. Probably this case could have been missed if we were not using AI software here. So what are the benefits of AI in oncopathology reporting? It improves accuracy significantly. The reproducibility of tumor identification and tumor grading is very, very high. As I said, there can be a lot of subjectivity in tumor grading, but AI software removes that. There is increased efficiency of reporting. The turnaround time is much faster. It can automate all the tasks which are time consuming, and pathologists can spend more time in more high level decision making. And of course, it's an excellent screening tool and audit tool also. Now, what is the future? I mean, this we are talking about what is presently being done in AI in pathology. The future is that a lot of AI softwares are being developed, some of which are now available, which can even identify the driver mutations which normally require very complex NGS-based testing. So without being tested for NGS or next generation sequencing, on HE slides, the tumor mutations can all be identified using the various AI softwares. A lot of generative AI solutions are now available, which help us which are made for pathologists, and these are, these are more, more like Chat GPT, but not exactly Chat GPT. You can submit your images to the software, and software will help us in identifying the type of tumor and more details about that tumor. So these are basically help to pathologists. So more useful for the students and the young pathologists. Similarly, a lot of content-based image retrieval solutions are now available. You can there are softwares where you can, if you're not able to identify certain rare type of cancers, you can put in those images into the softwares, and softwares will come up with the solutions back to you. And you can use those and that will help you to assist those rare cases very accurately. As I said earlier, it also helps us in identifying micrometastasis, especially like in radical specimens, mastectomy or hemicorectomy specimens. A lot of lymph nodes are dissected. Now, lot of time goes into screening those lymph nodes. Sometimes there are micrometastases, which are sometimes missed by the pathologist. Now, we actually did a very large study, and we presented this as a poster in the recent US CAP conference also in the month of March recently, which was held in Boston, USA. So in which we found out then that in two of our cases where pathologist was not able to identify micrometastasis, AI soft module actually identified those single tumor cells which were infiltrating into the lymph nodes, and that was later on confirmed by using IHC. So, this is a revolution, and we are now planning to use these softwares into our routine practice also. There are a lot of errors that can happen with AI diagnostics. So, basically AI tools are as good as they are taught by the pathologist. So, you have to feed in lot of information, lot of variety of information into the AI tools when the AI tools are being developed or the models are being trained. So if the data set is not elaborate and the annotations are not accurate, that will lead to incorrect reporting or incorrect deployment of those AI tools, and then the results of AI softwares will also not be very useful. So it is important that the AI tools that we use are very well validated and accurately developed onto a very large data set. So, and whenever we are using, we do a lot of internal validation also. Though the developers, they do a lot of validation, but when we deploy it in our settings, we also do a lot of validation on our cases so that all these tools perform very accurately in our settings. Of course, there is, as I said, the validation is important. There are a lot of ethical issues and regulatory issues since AI is new in medical sciences. So all these ethical and regulatory issues need to be handled. There are security and privacy concerns also. People think there can be impact on employment, and of course, these AI tools they are not very cheap to come. So we have to measure the cost benefit ratio also. But of course, we must know that the pathologists themselves have a very vital role in minimizing all these errors which can be created by AI. So a subject knowledge and as I said, very robust validation of the AI tools is very, very important before AI adoption is done by the pathologists. So in the end, I would, as a take-home message, I would like to say that humans are probably still the best suited uh, uh, for managing the creation of new information and discovery and new ways of approaching diagnosis. prognosis and treatment, and they can detect and deter the AI generated nonsense. So, but they also need help in getting through ever increasing workloads accurately and efficiently. And this is where AI will certainly be able to help us. So we have to work hand in hand with AI. So in pathology, all I can say is AI is not the final diagnosis, but AI is the assist to a pathologist who has to measure the outcome of AI results, and in the clinical setting only give his or her own diagnosis based on the AI assist. So the last statement, I mean, by the legendary physicist Stephen Hawking, who said that success in creating effective AI could be probably the biggest event in history of our civilization, or the worst. We just don't know. So we cannot know if we will be infinitely helped by AI, or we will be ignored by it and sidelined, or conceivably destroyed by it. So it is in our hand on how to utilize the results of AI. So thank you very much. This is the place where I work. This is our National Reference Lab, Dr. Lal Path Labs at Rohini, Delhi. We are proud to host the largest histopathology center, not only in the country, but in Asia. And we have a team of large, about 50 histopathologists working for us, almost 20 from this center and 30 from other locations across the country. And this is our large team at National Reference Lab. Thank you. Thank you very much. I'll be happy to take if there are any questions.
Thank you, sir. A very nice and exhaustive coverage of the topic. You have beautifully covered the entire topic. I just want to learn from you as currently what we face in oncology from the diagnostic. It is that it takes too much time, the diagnostics, especially biopsy, then ISCs, now the NGS coming, sometimes 3 to 4 weeks or 1 month is required to accurately diagnose and stage
Right.
the things. So will the AI, as you have mentioned, you are hopeful will shorten this time interval, and some point of care kind of thing will be there with the help of AI. And second, a very interesting path GPT like Chat GPT you have mentioned in your topic. So do you think apart from students and trainers, it will help? It will work something like a digital pathologist. As you know, very few oncopathologists are there in India, like in our city, Tri-City, Chandigarh, for maximum oncology test, we have to send the sample to Delhi or other tier 1 cities. Do you think with the help of PathGPT and human oncopathologist, there will be some kind of digital pathologist in the future? We will, can we hope for this?
Yes, thank you, Dr. Bansal, and very good questions. I mean, yes, I'll take up the first question first. So, I mean, you said that rightly said that the molecular testing sometimes take a lot of time. And do we expect some reduction in turnaround time with AI? The answer is yes, definitely. And how it will help? As I said, I mean, in my presentation also, lot of AI tools are being developed, some of which are already available in the market, but commercially, I mean, they need a lot of validation. So I will talk about one tool which we are currently working on. I mean, it is not, we have not yet launched it commercially, is for ER/PR, HER2 and Ki-67 testing. As you know, when the breast carcinoma is diagnosed, I mean, every case before going in for chemotherapy requires ER/PR, HER2 testing. Now, this is a immunohistochemical stain, which usually takes 3 to 5 days. I mean, if it needs to be repeated, maybe one more extra day. With this AI tool that we are presently in the phase of testing pilot only, we will not be required to perform the IHC staining. Directly, as soon as you diagnose cancer, using the AI tool, you will also get the information that whether it will be ER/PR positive or negative, whether it will be HER2 positive or negative. Now, I mean, in maybe next less than 6 months time, we are going to launch it, and it will be in the phase of clinical testing, and we would request you and other oncologists also to share your cases with us so that we can use those cases for the actual clinical testing, and we will take your inputs also that how it works for you. So that will reduce the time by at least 4 to 5 days. Similarly, lot of molecular testing tools are now coming up. As I said, AI will help in identifying the mutations also without actually testing for NGS or for fish. So once that is available, that will reduce lot of time. I mean, NGS testing and mutation testing, all these take, I mean, as you rightly said, maybe 15 days or sometimes more in some cases, because all these are batch-based testing and they have longer turnaround time. If the testing is not required at all, you just need to put in the slide and submit it to AI, and AI will give you the mutation. I mean, that much time is saved. So yes, the answer is yes. In future, AI tools will definitely help in reducing the turnaround time of these molecular tests. And about the second question, again, the answer is yes. And I mean, yes and no. I mean, yes, because these ChatGPT tool, I mean, I did not show it for because of paucity of time. It was a short video. I can share it with you separately. Uh, it gives lot of information. I mean, you submit a slide and it will give you lot of information about that case. So pathologists who are not, I mean, very much experienced in oncopathologists, it will be a very good assist to them. So, but yes, they gradually they will also need some experience so that they develop confidence in using these tools and reporting through these tools only. So presently it's just an assist, but yes, in future, I mean, it can go little beyond the assist also.
Thank you, sir. Thank you so much for enlightening us. Thank you.
Thank
For
you.
the
Thank you very much. Thank you for the opportunity.
next session,
Yeah,
I
Mukesh,
welcome. Yeah,
Dr. Mukesh, I would like to have a question from Dr. Rajiv.
sure, sure.
Yes,
Go
Dr.
ahead.
yes.
Rajiv, this is Dr. Nitish. So,
Yeah,
as you said that this test is going to come in the recent in few of the months. So
yeah,
my thing is because of the HER2 testing, which we have gone up to ultra low level and low HER2 levels.
yes.
So how are you going to predict those things in this report?
So as I said, I mean, this will go in a stepwise manner. So whatever we are presently testing and which will come up now in next few months' time will only be prediction of positive versus negative. I mean, so if something is negative, that is negative, and something if something is predicted as positive, therein we will have to do IHC testing to go into more details, whether it is ultra low positive, or positive, I mean 3 plus positive. So, but yes, that is the next step. I mean, a lot of more people are working on those models also, because ultra low is a very recent development and it has come into practice very recently. So presently no models are available to predict ultra low, but yes, the models are available to predict negative versus positive only presently.
Right. Thank you.
But
Thank
we
you.
can expect that in future, I mean, those models will also come.
Okay.
Thank you, sir. Thank you,
Thank
Dr.
you.
Thank you. Thank you.
For the next session, I welcome Dr. Priyanshu Chaudhary, who is Senior Consultant Medical Oncology at Livasa Hospital, Mohali. He will be discussing the clinical insights in lung cancer and the ASCO updates of 2025 in lung cancer. Dr. Priyanshu, over to you. Kindly invite your panelists.
Uh, Thank you, Dr. Mukesh. A very good evening to all. And kindly let me share my screen. So, a very good evening to everyone. I'd like to invite my panelists, Dr. Ketan Dang from Fortis Mohali, Dr. Nitish Garg from Sohana Hospital Mohali, Dr. Moveen Mittal from Patiala, Dr. Kanika Sharma from Max Mohali, and Dr. Prabhat Gunju from Homi Baba Mullapur.
Dr. Ketan is not available due to some
Okay.
emergency. Rest,
Okay.
I think all are there.
Rest everyone is there. As I can
Yeah.
see.
Hi. Good evening.
Good evening. Dr. Kanika is there.
Good evening, good evening,
Sir.
good evening, everyone. Yes, everyone is there.
Okay, so I have 20 minutes. I will request probably 2-3 minutes more. So first we will go on our NSCLC. So I think I'll start with Dr. Nitish. So Dr. Nitish, what percentage of NSCLC patients undergo surgery? I just need a ballpark figure, bang on target. We don't have much time. Over to you.
Less than 10%. I
Less than
have not
10%.
seen any of them in my practice.
Okay, Dr. Moveen,
5 to 10%.
10%. Dr. Kanika,
5%.
5%. Dr. Prabhat, maybe more.
Yeah, I think I would say 10%. Yeah.
10%. Okay. So again, is neoadjuvant therapy a routine practice for patient to undergo surgery in SCLC patients, or do you have a certain, category based on the T or N stage where you would like to use? Dr. Kanika?
Recently, most of my patients, they have undergone surgery first, followed by the adjuvant therapy. But yes, if the surgeon is hesitant and there are, maybe lymph node suspicious, then neoadjuvant may be considered.
No size consideration of the primary, nothing? I mean, if it's a 5.5 centimeters, still, if the surgeon says
Yeah,
it
if it's
will
a
be.
borderline, definitely. So,
Maybe
but
if
even
it
if
is a
it's
5
5
centimeter
centimeter,
lesion,
they have to do a
surgeon says
lobectomy.
we'll negative. The surgeon says I'll operate.
Yeah, so they operate.
Still, okay. So again, Dr. Moveen, same.
That depending on the feasibility of a surgeon and whether he's comfortable that he can do. Whether when this surgeon is in doubt, then definitely we will proceed with the neoadjuvant chemotherapy.
Dr. Prabhat?
So I think it's definitely case to case. In patients who have a larger tumor, larger nodes, maybe who are N2, we would like to give them neoadjuvant chemo or immuno. Also, I think this lies on the discretion of the surgeon. If they feel that it is operable, it's very easily operable, then there is no harm in going for an upfront surgery.
Okay, so maybe single station N2 or a large T size, if you say. Okay. So Dr.
Yeah.
Nitish, any difference of opinion?
I think the same thing. Only thing is the recent most trials have reduced the size of the primary lesion up to 4 centimeter or 4.5 centimeter also along with the nodal disease. And if the nodal disease is not there, again 5 or 5.5. But again, everything depends upon the surgeon, how a thoracic oncosurgeon takes it. And if he's very comfortable in operating, then yes, why not go ahead with upfront surgery?
Okay. So I think we all agree that we don't believe in PAT CR when it comes to lung, maybe. So I think I will then move on to our ASCO 2025 data, which we have right now, the Checkmate 816. That is a long-term OS data of neoadjuvant nivo plus chemotherapy in patient with resectable NSCLC. So this was again a 5-year analysis. We have already seen the EFS benefit observed with nivo plus chemo, and again increased number of patients having a pathological CR. ctDNA in the pre-surgical phase was associated with improved OS regardless of treatment. So this is, we know that about this trial. Again, stage 1B, that is more than 4 centimeters, to stage 3A NSCLC, ECOG PS 0 to 1. There is some lag. Yeah. So 3-weekly Nivo, 360 mg plus chemo versus chemo alone, surgery within 6 weeks, post-treatment and optional adjuvant chemotherapy or RT, or maybe again a Nivo up to 1 year. So the primary endpoint was PCR and EFS, and key secondary endpoint was OS, for which we have data now. This is again, so the final OS with neoadjuvant Nivo plus chemo versus chemo not reached versus 73.7 months, hazard ratio of 0.72, that is 28% reduction in the risk of death, and a 5-year OS 65% versus 55. Again, lung cancer specific survival even better, 75% versus 65% at 5 years. The hazard ratio even better, 0.65. EFS, again, 5-year analysis, 59.6, almost 5-year EFS versus just 21.1 with chemo alone. 49% 5-year EFS versus almost 50%, I would say, versus 34% with chemo alone. Again, as expected, as we have seen in other cancers, patient who have a PAT CR, they do well. Even with, if you see chemo PAT CR, they are doing well. And patient who do not achieve PAT CR, even after neoadjuvant chemo plus IO, they are not doing that well. Then coming to the OS by ctDNA clearance study, again patients who had detectable ctDNA levels, they had a poor prognosis, poor overall survival. The ctDNA was detected just before surgery, irrespective of the treatment which they had received. So safety summary, we all know the similar, to other IO side effects which we have seen. So in this pre-planned final 5-year analysis, 5-year OS rates 65% with Nivo plus chemo and 55% in the chemo arms respectively. Nivo plus chemo showed improved lung cancer survival, lung cancer specific survival versus chemo. Again, patient with PAT CR with neoadjuvant Nivo plus chemo had a 90% reduction in the risk of death by 5 years versus those who did not achieve PAT CR. Pre-surgical ctDNA clearance was associated with long-term OS improvement, and safety profile was consistent with previous reports. And we have OS data now available for Checkmate 816. So, again, over to the panelist, Dr. Nitish. Considering that you are planning to use a neoadjuvant IO combination with chemotherapy, what would be your, do you go for some biomarker testing before starting, or, irrespective of biomarkers?
I think biomarker testing in lung has become must now. I definitely do it, but not specifically PDL1, just to find out if there are any driver mutations or not. So that
So
is
do you
the
go for an
only.
NGS, or do you go for some other testing in a perioperative case?
In a perioperative case, yes, NGS, lung NGS panel, a complete panel is sufficient enough.
So 3 weeks time it will take. Would you wait for the report to add an IO?
IO, I can start with the chemotherapy and add IO later. But usually now the NGS is taking less time. Fortunately, it has come down to 14 days. So probably within 14 days we'll get some result. And
I
if
think
I
Sunday
have
is
to
not
get
included in that.
if I have to get only EGFR, which I might be thinking of, I can just get a EGF PCR for RT-PCR for EGFR, which may be sensitive enough, but I've not used that idea often.
I think EGFR and ALK we can do and get a report within 5-6 days.
Yes, yes.
Yeah. So that is a good option, I think. Dr. Kanika, your take on this?
So in the definitive setting, so in the pre-op setting, EGFR and ALK we usually do. In the advanced setting, the NGS panel can be done, and as Nitish said, start with the first line of chemotherapy and then modify later on. But in
I think in
either
the adjuvant setting also, and EGFR, ALK, and PDL1 would be sufficient, I think. Dr. Prabhat, your take?
So I think obviously do an EGFR AL cross. PDL1 usually not required in this perioperative setting. Yeah, I think we can wait for the mutation panel to start chemotherapy, chemo or immunotherapy. I think that's not a bad thing to do.
Okay, Dr. Moveen, your take?
Definitely, we will start with chemotherapy, and meanwhile, the report will come. Definitely, can add immunotherapy along with the chemotherapy.
Okay, so I think everybody is of the opinion that we can start chemotherapy and maybe. So, what is the maximum number of neoadjuvant chemotherapy cycles which you would like to give, Dr. Moveen?
After 3 to 4 cycles, then definitely we can have evaluation.
Okay, so if there's stable disease, would you like to give more, or take him up for surgery?
Definitely, after the surgeon opinion, if the stable disease, if the patient surgeon is comfortable with surgery, then definitely we can proceed with surgery. And if the surgeon wants 2 more cycles to be done then we can have 2 more cycles, and after that we can have surgery.
Okay, fine. So I think the trial has used mostly have used 4 cycles in the neoadjuvant setting. Anyway, so now we again, if the patient comes out to be an EGFR mutated, so what is the data which we have? So we have neoadjuvant osimertinib plus with or without chemotherapy versus chemotherapy alone in resectable EGFR mutated NSCLC, the NeoAdora trial. We all know that. So we'll go on the study design. Phase 3 randomized study, uh, confirmed non-squamous NSCLC with del 19 or L858R ECOG PS or WHO PS 0 to 1. Randomized 1:1:1 to 3 arms, OC plus chemotherapy versus OC monotherapy versus placebo plus chemotherapy alone, followed by surgery. It was given up to 3 cycles or 9 weeks, which we have seen. So R0 resection was achieved in more than 90% of all the patients. Again, now coming to the major pathological response, that is more than 90% reduction in the tumor viable tumor cells. So it was with osimertinib plus chemotherapy and osimertinib monotherapy, it was 26% and 25%. So it is almost equivalent in these two arms versus just 2% with chemotherapy alone. So I think this is very important, and chemotherapy alone might not be sufficient in the neoadjuvant setting. It was consistent. The MPR benefit was consistent in all the predefined subgroups. The depth of pathological response was greater with OC containing regimens. We all know nodal downstaging, over 50% of the patients with baseline N2 disease were downstage at surgery with both OC containing regimens. This is very important compared to only 21% with chemotherapy alone. The odd ratio is more than 4 when compared to chemotherapy in both OC arms. Again, interim EFS analysis, hazard ratio 0.73, OC containing regimens are better. OC plus chemotherapy 0.50, OC mono is 0.73. Again, those who had MPR are doing well at 15 months cutoff. Safety, they were consistent with the previous side effects. We have used osimertinib with chemotherapy in the metastatic setting also. So no new side effects. Majority of side effects were non-serious. Then to conclude, neoadjuvant osimertinib with or without chemotherapy should be considered when planning treatment for patients with resectable EGFR mutated stage 2 to stage 3B NSCLC. So even for 3B disease, we have an option now of using neoadjuvant chemotherapy plus osimertinib or osimertinib alone in patient who have a planned for surgery or might be potential surgical candidates. So now coming to two abstract we have for small cell moving from NSCLC to SCLC. So Dr. Kanika, what is the standard of care in extensive stage SCLC in your clinical practice?
Say C2 plus immuno, atizo mostly.
Okay, so atizo. Dr. Prabhat?
Yeah, chemo immuno, either durva or atizo, depending on the chemo partner. Yeah.
Okay. Any particular choice?
If I'm using cisplatin, then obviously I prefer to give it with durvalumab. With carboplatin, I think atizo is an option. And otherwise, I think both of them are almost equal.
Okay. Dr. Nitish?
Keto, cis plus either of the immuno.
Okay, so you're preferring Dr. Moveen?
Same, Ito plus cis or atezolizumab or durvalumab, anyone can be used.
Okay. So, is there any
What is the logic of using cisplatin with durvalumab? Some study or something?
I didn't get you, sorry.
Dr. Prabhat mentioned that if I'm using cisplatin then durvalumab, is there some study that it is beneficial to use the combination of these?
But durvalumab usually has
trial.
yeah,
Yes, sir.
durvalumab usually has better data than atizo, and it's been used. So if we're using CIS, we have both the options. And so if we have both the options, then I think I would choose durvalumab over atezolizumab.
That's
Yeah,
it.
the trial settings were like that. They used up to 6 cycles, 4 to 6 cycles, and they allowed both cisplatin and carboplatin in the ratio, I think, 2/3 to 1/3. So that was based on the trial designs of, these drugs. But I think in clinical practice, there is considerable overlap. So, is there any unmet need in SCLC? And what is your maintenance regimen currently, Dr. Kanika?
Currently, only immunotherapy if there is a significant response, and PCI with maybe consolidative RT to thorax.
So, I mean, along with immunotherapy, also, if you are using PCI, or do you use it only when you're using chemotherapy?
No, with the combination also.
With
Yeah.
combination also. Okay, so no 2 monthly MRI, straight away PCI preferring. Prabhat, your take, Dr. Nitish.
I think when we plan to use immuno as a maintenance, role of PCI becomes limited. But yes, we can always use it in case the patient is not willing for a repeated MRIs. Option is always given, but MRI during the follow-up can also be a good plan.
Dr. Prabhat, what's your practice?
So PCI, usually in the immunotherapy era, I think PCI I would still consider. Thoracic consolidated RT is questionable. But as of now, we are still offering for those patients, even though immunotherapy is given.
Okay, so we all believe in giving PCI. So I believe in reducing my load of RT people because our machine is pretty old. So coming to 2025 ASCO data of lurbinectedin plus atezo as first-line maintenance treatment in patient with extensive stage SCCLC, that is the phase 3 IM-40 trial. So we all know the background. So this was the study design. Treatment naive, ESSCLC, no CNS metastasis, very important, ECOG PS 0 to 1. And they had an induction phase of atezo plus etocarb 4 cycles every 3 weekly, followed by a screening, ongoing CR, PR, or stable disease following induction therapy. Then again, randomized to maintenance phase of lurbinectedin 3.2 milligram per meter square plus atezo every 3 weekly versus atezo alone until progression or unacceptable toxicity. There was no crossover allowed. So again, coming to the investigator PFS, which we see from randomization into maintenance phase, it was again 5.4 versus 2.1, hazard ratio 0.54. Again, almost all subgroups are benefiting. Coming to the OS, it was again better, 13.2 versus 10.6, that is a 0.73 hazard ratio. 12-month OS of 56.3 versus 44.1. OS from randomization into maintenance phase, because randomization was just post the induction. Again, it is 13.2 versus 10.6. So this trial showed PFS benefit, a hazard ratio of 0.54. OS benefit, hazard ratio of 0.73. And the benefit was generally consistent across the majority of subgroups. There were numerically higher grade 3 and 4 adverse events, which is expected with the addition of another DNA inhibitor, if we say. But there were no clinically meaningful increase in the immune-related adverse events, and it is the first phase 3 study to show PFS and OS improvements with first-line maintenance treatment for ES-SCLC, highlighting the potential of lurbinectedin plus atezo to become a new standard of care for first-line maintenance therapy in patients with this aggressive and difficult to treat disease. So I think we have another option now, pending the availability and cost analysis, which we will have to do. And maybe we are using a drug which is probably used for second line and converting into maybe a maintenance drug and delaying the progression, or maybe the platinum sensitive period. So now again, what is the second line treatment option post atezo? We have used etocarb atezo. What is the standard of which we are using in our clinical practice, Dr. Moveen, for second line?
Um, Second line chemotherapeutic agent which we can use is the irinotecan or paclitaxel. We can use nab-pacli. There are many options.
Okay, so what is your choice?
If the patient is fit and performance status is good, then definitely we can have irinotecan. And if the performance status is poor, and we can have nab-pacli.
Okay, so Dr. Kanika, what percentage of your patient would actually receive second line?
Around 60% of them.
Okay, and your choices? I don't know.
Mostly iron, no, based on.
Topotecan, anybody, or I don't know, is I think good enough. Dr. Prabhat?
So I usually will see the cisplatin, the duration when the platinum was given, platinum-free interval. If in a small cell kind of a setting, around 6 months is quite good. I think we can re-challenge. So I would combine irinotecan with cisplatin or carboplatin and give. Otherwise, if not fit for that kind of a therapy, a low dose irinotecan, or then the third option would be single agent paclitaxel.
I think for small cell, we can, I mean, it's all arbitrary, but I think 90 days has been used in some studies as a platinum sensitive period. And if we are on maintenance, at ESO, we probably would have that period in a lot of our patients. So irinotecan plus carboplatin is a good option, I think, that can be used, which actually I've used weekly also. Dr. Nitish, your choice?
I think the same thing. More than 6 months or approximately 6 months of cisplatin, a patient has tolerated and done well.
Do you really,
Irinotecan plus.
do you really get patients who are, post chemotherapy are, having a PFS of 6 months? Do you have? Because I don't have much patients.
I don't have. So I actually have to go to single agent irinotecan. And in some patients, yes, I have used topotecan, where the patient is not tolerating the irinotecan much, but it was only a couple of patients. So again, not a great response.
Okay. So
I
coming
think
to our
3 months is a good. I think 3 months is a good interval to re-challenge platinum.
Yeah. So I think it has like 45 days is for completely, if I'm not wrong, completely, I would say platinum resistant, and from 45 to 90 is partially platinum sensitive, and more than 90 is platinum sensitive. This is what I remember from when I studied it. So we have another data now coming from ASCO 2025. Tarlatamab versus chemotherapy as second line treatment for small cell lung cancer, the Delphi 304 study. Uh, you know, it is again, it is a bispecific T cell engager. We have a bite here that directs cytotoxic T cells to DLL3 expressing small cell lung cancer cells, resulting in tumor cell lysis. And it has demonstrated durable anti-cancer efficacy in patients with previously treated SSCLC. And this Delphi 304 study was conducted to assess whether tarlatamab would improve OS for patient with SCLC whose disease had progressed or recurred following one line of platinum-based therapy. So again, inclusion criteria: SCLC progression after first line platinum chemotherapy, with or without anti-PD-L1 therapy, ECOG PA 0 to 1. Brain mets treated or untreated, brain mets asymptomatic. Again, then, they have used chemotherapy-free interval of less than 90 versus more than 90, and less than 180 and more than 180 as a stratifying factor. And again, prior anti-PD-L1 therapy, presence of brain mets, yes or no, and chemotherapy, topotecan, amrubicin versus lurbinectedin. Again, randomized 1:1 to tarlatamab and versus chemotherapy, baseline characteristic well matched. Then it met its primary endpoint of overall survival versus chemotherapy alone, a hazard ratio of 0.60, 13.6 versus 8.3. At 12 months, 53% survival versus 37%. I think what has happened. Is my screen sharing still visible?
Yeah,
Yeah,
it's visible.
sorry.
It's visible.
So I had just some issue with my.
Sir, would request you to conclude your presentation
Yeah,
in
yeah,
2 minutes.
take 2
Yeah.
minutes. Yeah. Okay. So again, we have benefit with respect to overall survival. Almost all subgroups are benefiting. PFS again 4.2 versus 3.7, 15 days benefit with this drug in second line and hazard ratio of 0.71. I'm not very sure what would be the cost benefit of this drug. Lower incidence of high-grade adverse events surprising with tarlatamab compared to chemotherapy. So to conclude, we have another drug, superior survival outcomes coupled with favorable patient-reported outcomes and safety profile that affirm tarlatamab as a standard of care for second-line treatment of SCLC, and it establishes a new paradigm for bispecific T-cell engager immunotherapy and lung cancer. So last question to all the panelists is open for all. Would you be willing to use this drug if you see at the half a month PFS benefit to all the
As of
panelists?
as of now, I feel it is going to be difficult to answer that. Half a month with your bank account getting empty might not be a healthy discussion on also, but maybe
But we have
we
used
have to.
gem and lorlatinib with 6 days
By the
benefit.
time we were able to use it, we have a more data about
Yes,
it.
yes. So if we have more data, and by the time it comes,
I
we'll
think
definitely have more
there
data.
is a with the median PFS, we also have to see what percentage of patients are actually responding well. So I think that data also, even with immunotherapy, sometimes you have, PFS curves crossing and still you blame it on early hyperprogressors and then, still use those combinations of PDL1 and CTLF4. So I think if you have maybe 10 or 15% patients who have a very good response compared to chemotherapy where you have maybe a 5% or 2% response. So I personally might be inclined to use and not just see the median PFS because it's a very bad disease and most of the patients would not be doing very well. So that is my personal take. Dr. Prabhat and Dr. Moveen, anything to add from your side?
Definitely, data is very immature, and further studies are required. And definitely, the cost of the drug, as the PFS benefit, and is not much, and the cost if it is not tolerable by patient, then definitely it's no use to use such medicine.
I think more studies won't be there, I think, but we can have more of longer follow-up and we can see.
Yeah, yeah.
Maybe, yeah. So Dr. Prabhat, is he here or is he left?
Yeah. I think we would want to see which subset of patients actually respond to tarlatamab. And those, I mean, if we can identify that subset, then probably we can use. But otherwise, it'll be difficult to convince a patient to take this drug over chemotherapy, with just that much benefit. That's the only thing.
Assuming no financial, constraints. I think we might have some data regarding the subset of patients with for molecular testing with the expression of this bispecific receptors DCC3 or whatever be the three. So I think we might have some subgroup analysis later on coming. So
Yeah.
thank you everyone, and we had a wonderful discussion. Over to the organizers.
Thank you, Dr. Pranshu, and all the panelists
Thank
for the
you.
wonderful discussion. I think you had a difficult work with the some discussing so many abstracts in such a short span of time, and but you all have done a wonderful job of it. Thank you. In the paucity of time, I will quickly move to the next session. So I welcome Dr. Sandeep Kokar sir, who is Director Medical Oncology at Sohana Hospital, Mohali. He will be discussing a new era integrating immunotherapy into limited stage small cell lung cancer management. Over to you, sir.
Thank you, Dr. Mukesh, for the invite, and I hope I'll do justice to what has been asked by you to present something on new era on upcoming era of immunotherapy in LS-SCLC, localized stage small cell lung cancer. Just give me a few moments. I hope the slides are visible.
Yes, sir.
Yeah, sir. Yeah.
Slides are moving.
Yeah.
Yeah, thank you, Dr. Mukesh, for giving me the invitation. And I'll quickly move on to the discussion on small cell lung cancer. And we all know that LS-SCLC accounts for around 15% of the cases, whereas extensive stages, whereas the non-small cell lung cancer cases account for around 85% of the cases. Patients who present with small cell lung cancer, they usually have a poor outcome because majority of them, they do have brain metastasis at some point of time. Also important to highlight that the disease almost exclusively occurs in approximately 90 to 95% of the patients are smokers, and the median age of presentation is around 60 to 70 years, which is an elderly age group. Among these small cell lung cancers, around 1/4 of the patients are LS-SCLC, and the rest of the around 3/4 of the patients are extensive stage SCLC patients. And the management, we all know either it is surgery or a definitive CTRT based approach. And with all the techniques that we have at present, the outcomes are dismal. Even if the patient presents in LS-SCLC, the median PFS is around 170 days and the median OS is around 190 days. So you can assume that there was an unmet need in this subset of patients where the patient usually present in a localized stage where definitive treatment can be offered, but ultimately they do present with an extensive disease or a metastatic disease at some point of time, despite having a very initial response to concurrent CTRT. So there is an unmet need. We need to improve the survival in such cases. And we all have the extrapolation of the data from the extensive stage as well as the extrapolation of the data from non-small cell lung cancers where immunotherapy has already been established as a standard of care. So here you are seeing at a median OS of around 25 to 30 months. Majority of the patients, they suffer from a relapse despite the initial response, and approximately 30% of the patients are alive at around 5 years of survival. So why? Because there is either a thoracic recurrence or a CNS recurrence. So what the discussion was being highlighted by Dr. Priyanshu, whether there is a need for a PCI or not in the era of immunotherapy. Let me come to that also. So this is something about the classification. We all know that either it is the limited stage where the area can be encompassed into a single radiation port corresponding to the stage 1 to stage 3B. Extensive is when it cannot be encompassed in a radiation port, and either it is a metastatic disease beyond the lung boundaries, extending to liver, adrenals, or the brain part. So this is about the treatment armamentarium. Limited, either it is surgery or a CTRT based approach followed by a PCI. And extensive, I'll not be covering the extensive part here. So the current landscape of treatment, we all know that it is the concurrent CTRT with a cisplatin etoposide with radiotherapy is the preferred treatment option across the globe. Patients with poor PS, they can be considered for a sequential based treatment with either initially 3 to 4 cycles of neoadjuvant therapy followed by a CTRT. Surgery, if the patients they do present in an early stage, they can be operated followed by an adjuvant chemotherapy with cisplatin and etoposide, or they also can be offered a concurrent CTRT based approach for a minor subset of patients. There were no approved targeted therapies till the presentation of Adriatic trial, which established that immunotherapy can be offered to patients who have been treated with CTRT in LS-SCLC. So this is about the CTRT. Preferred is either cis-eto 4 cycles plus CTRT with 1 to 2 cycles of chemotherapy. The standard recommended radiotherapy is 45 gray, 2 daily fractions in 30, twice daily in 30 fractions, but majority of the times it is either a single fraction 5 days a week for around 5 to 6 weeks. So this is about concurrent CTRT, which is being preferred over the sequential chemotherapy. So the role of PCI as being highlighted by earlier speaker, because around 50% of the patients will have a risk of brain metastasis, and even after a very good response initially, majority of the patients they do turn out to have a CNS mets, we definitely there is an unmet need here to avoid radiation because of the neurotoxicity and the neurocognitive effects. But as far as the data is concerned, it improves the overall 3-year overall survival by around 5%, and it cuts down the risk of brain mets by around 50%. There are two different studies. One is the Prima lung study, and the other is the Maverick study, which is currently evaluating the role of MRI surveillance versus offering a PCI plus MRI surveillance for patients to avoid the use of a prophylactic cranial irradiation so as to avoid the neurocognitive effects. So the role of immunotherapy in SCLC in the first line, we all know that this is for extensive stage. I'll come to the localized stage. So this is the Adriatic study, which was a phase 3 randomized, double-blind, placebo-controlled, multi-centric international study where patients in stage 1 to stage 3, stage 1 and stage 2 inoperable, they were offered CTRT, concurrent CTRT, and PCI was permitted. CCRT components included the use of a cisplatin and etoposide based approach along with the radiation that I was talking about, 60 to 66 gray over 5 to 6 weeks. Then the patients were randomized within 42 days of treatment to durvalumab versus placebo every 1500 milligram every 4 weekly. The primary endpoint being the overall survival and the progression-free survival by blinded independent review committee. And the key secondary endpoints were, there was a third arm also, durvalumab and tremelimumab, which was again, it was merged with durvalumab only. So we have the analysis of durvalumab plus placebo arm only. So the baseline characteristics were well matched, approximately PCI versus non-PCI, 50-50%. They all were almost very, very similar. And if you look at cisplatin versus etoposide also, the majority of the patient, they do receive cisplatin with etoposide, approximately 1/3 of the patient receiving carboplatin with etoposide. Rest of the characteristics were well matched. There was a significant improvement in the overall survival to the tune of around 22 months, 55 months versus 33 months with a hazard ratio of 0.73. Very impressive. Again, the overall survival was again consistent with all the subgroups. Particularly important to highlight whether the use of PCI was there or not. It favored the durvalumab arm. Progression-free survival was also improved to the tune of around 7 months, 16.6 versus 9.2 with an impressive hazard ratio of 0.76. A 2-year PFS rate of around reaching approximately 50% of the patient did not have a disease progression. PCI versus non-PCI, again important to highlight, the difference was almost very, very similar. This is about the recent analysis that we are discussing, that is the PCI versus non-PCI, what to do. The current standard of care says better to offer PCI to each and every patient. But again, in the era of immunotherapy, there are two different studies, Prima lung and the Maverick study, which will be definitely highlighting the role of MRI surveillance versus doing a MRI surveillance with a PCI-based approach. Even though there have been trials, particularly in Japan, who have stated that with the use of hippocampal sparing radiation therapy, there is a risk of neurocognitive effects to the tune of around 25 to 30%. So to avoid those neurocognitive effects, we need to have a closer look that in the era of immunotherapy, whether PCI can be completely eliminated from the treatment or not. So here is the data, what the Adriatic study says, whether PCI was offered or not. Hazard ratios are very, very similar, and durvalumab clearly scores in terms of overall survival as well as in terms of CNS free survival. Hazards are to the tune of 0.71 versus 0.75. So whether or not patient received PCI or not, durvalumab is definitely gonna help those patients to have a better overall survival. So again, PFS benefit was again very, very similar. The hazards are to the tune of 0.7 to 0.8. Most frequent adverse effects that we all know, they are immunotherapy related effects. Particularly, there was a risk of around 5% of radiation pneumonitis compared to placebo arm, which was around 1.3%. So there is slightly increased risk of radiation pneumonitis. The rest of the side effects are almost very, very similar that we all know about what has been there in the treatment with immunotherapies. So durvalumab is the first and only approved immunotherapy in LS-SCLC to demonstrate statistically significant improvement in OS as well as PFS, where particularly in the setting where the disease is curative and there are going to be the patients are going to relapse in few course of time, and they are going to relapse at such sites where again the morbidity is very, very high, particularly in the setting of brain metastasis. So concurrent CTRT is the current standard of care. Durvalumab as a consolidation therapy after CCRT offers a significant and meaningful benefit in terms of OS and PFS. So it is definitely to be offered, particularly as a consolidative treatment for up to 2 years. And the safety findings reveal that they are very, very consistent as we have learned from our other data with durvalumab, particularly in extensive stage SCLC. So it is the only immunotherapy across stages of SCLC, whether it is limited or in the extensive stage, that has offered OS and a PFS benefit. So that's all from my side. I'll be happy if there are any questions at the end of the session. Thank you.
Thank you, Dr. Sandeep Kukar, sir, for the nice presentation. You have beautifully summarized the whole data. How many of your patients, sir, you were able to give the consolidation immunotherapy durvalumab in this setting? And I will also like to know from you, learn from you basically. Do you think that if we have a capped PAP like Atezo and Pembro in durvalumab, it will help in increasing the reach, specifically in small cell lung cancer?
So, Dr. Mukesh, I have not used in LS-SCLC. I have used it in NSCLC, where I think we all have been using since ages as a consolidative treatment post CTRT. And I think in many of the patients we have given durvalumab, and they are all almost able to complete the full course of treatment. Um, but in this particular setting of the Adriatic study, if you ask me, I have not used this setting. So definitely, if the PAP program is improved by Astra, the reach of the patients would increase not only in LSCLC, SCLC, but also in the extensive stage also. So I think cost is definitely a hindrance to treatment. The kind of patients we have, I think if the PAP is increased, so patients will definitely benefit from the support programs.
Thank you, sir. Thank you so much for the insights. So the next, yeah. Can Dhruv, you play the slides for me for the next
Yeah,
session?
sir. I'm just sharing slides from my side. Just a moment.
Yeah. So
So slides are visible.
yeah. So I will be discussing on the redefining the first line management of ALK rearranged non-small cell lung cancer. I hope you have played the correct slides, Dhruv. Next slide, please. The first line management of ALK rearranged non-small cell lung cancer, as we all know, it has gone a key change with the availability of the drug lorlatinib, which have shown wonderful results in the trials, and now we are seeing in clinical and practical scenario also. So next slide. Next. Yeah, next. So this is next slide. Next. Yeah. So we all know with the Globocon 2020 data, lung cancer is a common, very common cancer, fourth most common cancer diagnosed in India, and most of the patients are diagnosed in advanced stage. Next slide. So mortality rates are higher. There is a key unmet need in lung cancer, especially in metastatic. Next. Yeah, so incidence of ALK mutation, it is very variable. ALK gene rearrangement in lung adenocarcinoma is the second most common. It ranges from 1.6 to 11.7%. That is the what the data says, but practically, if I talk about my own experience, I think the rate is somewhere more to the tune of maybe 1 to 3% or less than 5%, not a 10 to 11%, which some of the reasons have. Next slide. So it occurs typically in adenocarcinoma histology, mostly non-smokers, but can occur in smokers also tend to occur in younger patients, in female patients, and EML4, ALK, and EGFR mutations are mutually exclusive. Next slide. So next, I think in the of time we will be little fast. Next, yeah, Dhruv, yeah. So there is an unmet need in ALK positive non-small cell lung cancer, as ALK positive are generally young and non-smokers. CNS mets occur in 20 to 40% of untreated ALK positive non-small cell lung cancer, leading to poor prognosis. Treatment challenges, even with the availability of second generation ALK TKIs are there. ALK resistance mutations occur. Inadequate penetration into the CNS is there. Durable control of brain mets is a challenge. And 1 in 3 patients do not receive second line treatment despite development of second generation ALK targeting agents with improved efficacy. Next. So ALK positivity and brain mets in newly diagnosed patients with ALK positive, the incidence of brain mets is 20 to 30%. International guidelines recommend testing for CNS mets at diagnosis through MRI brain. Several ALK TKIs have been evaluated in the first-line setting for ALK positive non-small cell lung cancer patients with baseline CNS disease, demonstrating prolonged PFS and intracranial efficacy. Lorlatinib is a kinase inhibitor indicated for the treatment of adult patients with metastatic non-small cell lung cancer whose tumors are ALK positive as detected by an FDA-approved test. So in the first-line setting, lorlatinib has the potential to manage and prevent the emergence of CNS mets in ALK positive. Next slide. So brain mets in oncogene-addicted metastatic non-small cell lung cancer, the incidence we have discussed, it is fairly common. Since metastatic diagnosis, we have seen it increases. Time since metastasis, it increases, and in 3-year cumulative brain mets around 58.4%. Next slide. So, and if it wasn't hard enough to choose one agent, first line, overall efficacy, survival, CNS activity, what matters the most? I think it depends on patient to patient, and we have to keep all the factors. Next slide. Next. It is a third generation ALK TKI. Excellent brain penetration, 75% to address the brain mets. Next. Next. So coming to the CROWN trial. Next. Yeah, so the key eligibility was stage 3B to 4, ALK positive non-small cell lung cancer, no prior systemic treatment for metastatic disease, ECOG performance status 0 to 2, asymptomatic treated or untreated CNS mets were permitted. So if the CNS mets are asymptomatic, untreated or also permitted, one or more than one extracranial measurable targetable lesions with no prior radiation required. 1:1 randomization, lorlatinib 100 mg once daily, 149 patients, and crizotinib 250 mg BD in the standard dose, 147 patients. Stratified by presence of brain mets and ethnicity. So primary endpoint, PFS by Becker analysis, secondary endpoints, PFS, overall response rate, duration of response, intracranial time to progression, overall survival, safety, and quality of life. Next slide. So baseline characteristics were quite similar. Age 61 in lorlatinib group versus 56 in crizotinib group. 56 to 62% of the patients were female. Asian patients were well represented, 44%. ECOG performance status mostly 0 and 1. Few patients were 2. Never smoked patients were 54 and 64%, and previous smokers were also there. Stage 4 disease was present in 91 to 95% of the patients. 95% of the patients had adenocarcinoma histology. Next slide. Brain mets at baseline were there in 26 to 7% of the patients. Next. So CROWN PFS. In the lorlatinib, median PFS not yet reached versus 9.3 months in the crizotinib. PFS by investigator assessment not reached in lorlatinib versus 9.1 in crizotinib group. The primary endpoint of PFS by Becker was met in the CROWN trial. Primary analysis and was supported by the secondary endpoint of PFS by investigator assessment. 12-month PFS rate is 78% in the lorlatinib versus 39% in the crizotinib group. Next slide. So 5-year analysis. Next. So after 5 years of follow-up, the median PFS with lorlatinib treatment has not been reached, with an investigator-assessed PFS rate of around 60%, which is unheard of, especially in metastatic lung cancer. This PFS benefit, which exceeds 5 years, is the longest reported PFS in advanced non-small cell lung cancer to date, compared to 9.1 of crizotinib, with a hazard ratio of 0.19, which again is almost unheard of. Next. So in patients with and without baseline brain mets, lorlatinib improved PFS with median PFS not reached in either group, compared to the crizotinib, where it is 6 months in the with brain mets and 10.8 months without brain mets, with a hazard ratio of 0.08 in brain mets group and 0.24 in without brain mets group. Next. Crown and Alex investigator assessed PFS again. Next slide. So time to intracranial progression. Lorlatinib delayed intracranial progression versus crizotinib. There were no intracranial progression events after 36 months. So 9 events in lorlatinib compared to 65 events in crizotinib. We can all see the results with a hazard ratio of 0.06. Next. Lorlatinib delayed CNS progression in patients with existing brain mets and delayed the onset of CNS disease in patients even without baseline brain mets, with a hazard ratio of 0.03 and 0.05. Next slide. Next. Next. So overall and intracranial efficacy were investigator assessment in patients with baseline brain mets. Lorlatinib resulted in high intracranial response, the majority of which were complete and durable response. Next slide. Subgroup analysis. Next. So median PFS in poor prognostic subgroup V3 was 60 months, demonstrating lorlatinib activity across all variants of EML4-ALK. Median PFS for V3 in the ALEX trial with alectinib was 17.7 months. So we can see it is almost a 3 to 4-fold increase in PFS in the worst performing subgroup of the V3A3V variant. Next slide. So median PFS in patients with P53, which is considered a poor prognostic marker in almost all the cancers, was 51.6 months, demonstrating lorlatinib activity in difficult to treat patients. Next. Next. So lorlatinib reduced hazard of progression compared to other treatments in meta-analysis. If we compare it with alectinib, brigatinib, ceritinib, crizotinib, or ensartinib, and chemotherapy, in all in this chart you can see it is to the left of the line, so it favors lorlatinib. So it is an effective first-line treatment for ALK positive non-small cell lung cancer when compared to crizotinib and other next-generation ALK TKIs. Next. No statistical difference between lorlatinib and other treatments for overall survival. However, OS was immature for many of the included studies. Next. So in terms of PFS, the results indicate that lorlatinib was the best treatment choice for patients with ALK inhibitor, naive or untreated, ALK positive advanced non-small cell lung cancer. Future head-to-head trials assessing the relative efficacy of lorlatinib, alectinib, and brigatinib are warranted. Next. So lorlatinib PFS advantage over alectinib and brigatinib in NMA. Next. Next. I think we will skip that in paucity of time. Next. So conclusion of network meta-analysis. In terms of PFS, the results indicate that lorla was the best treatment choice for patients with ALK. Among lorla, alectinib, brigatinib, and crizotinib, lorlatinib had the highest probability to reach the best overall confirmed response rate, probability of 48%, intracranial confirmed response rate 44%, significantly improved PFS than brigatinib and alectinib. No significant difference was found among them in overall survival and adverse effect analysis. Next. Resistance pattern after ALK decays. Next. So there are the various factors which lead to development of resistance to second generation TKIs, mainly domain mutations, particularly 120 G1202R. Next. So lorlatinib is a potent third generation ALK TKI which has a broad spectrum activity against most known ALK resistance mutations, including the most common one. Next. Sequencing of ALK TK generations leads to more ALK resistance mutations. So more generation of ALK TK was sequenced, more monster ALK resistance mutations appeared. So we have to hit hard in the first line alone. Next. Rationale for upfront use of pan inhibitory agent, as we have seen, because the mutations keep on coming, the resistance patterns keep on coming, the more monster, more lethal. Next. Next. Yeah, Dhruv, please play the slides. I think we will just conclude due to we are already late. Next. We have discussed all these things. Next. Safety profile. We all know that adverse effects with lorlatinib are largely manageable with concomitant therapies, temporary treatment interruptions or dose reductions. The permanent discontinuation rates are low and are comparable to crizotinib. Next. Just keep on playing this. Yes. Continue. Hyperlipidemia, we have to keep an eye on lipid profile as with other TKIs also. Next. So median time to onset and duration of selected adverse reactions, as I have already told, hyperlipidemia, edema, peripheral neuropathy, and weight increase. We have to keep an eye on these. Next. Just skip the adverse. Just management of, we all know. So 5-year analysis of efficacy by first lorlatinib dose reduction within 6 weeks. Next. 16. Adverse effects seldom result in permanent discontinuation, were generally manageable with dose modification or reduction. Treatment-related adverse events leading to permanent treatment discontinuation in 5% of the patients only, which occur during the first 26 months. Next. Dose reduction did not appear to affect the data, especially in the first 16 weeks. Next. So to summarize, lorlatinib offers more than 5 years PFS in first-line ALK positive advanced non-small cell lung cancer, the longest PFS ever reported in advanced lung cancer. 60% of patients were alive and progression-free. 92% of patients remained protected from CNS progression. The safety profile of lorla was consistent with that of the primary analysis. No new safety signals emerged after 5 years. Next. So the key takeaways: after 5 years of follow-up, median PFS is yet to be reached, corresponding to the longest PFS ever reported with any single agent molecular targeted treatment in advanced non-small cell lung cancer and across all metastatic solid tumors. So dose reduction, we have seen, to conclude, the systemic efficacy results are coupled with prolonged intracranial efficacy and the absence of new safety signals represent an unprecedented outcome for patients with advanced ALK positive non-small cell lung cancer and set a new benchmark for targeted therapies in cancer. So these are the guideline recommendations, the new standard of care. Next. Yeah, thank you. So,
So I would request you to invite Dr. Rajiv Gupta, as Dr. Rajiv Sani sir will be joining late.
okay, so we are just changing the session. No? Just a sec. So we are shifting to the this Atizo session, na? Okay. So for the next session, I will like to invite Dr. Rajiv Gupta sir. Sir is a professor, Department of Medical Oncology at Government Medical College, Jammu. He will be discussing the role of atezolizumab in first-line metastatic non-small cell lung cancer. Welcome, sir. Over to you.
Thank you, Mukesh. Dr. Mukesh, first of all, thanks for inviting me to this esteemed discussion and academic program. And I'll be speaking on the topic, the role of atezolizumab in the management of non-small cell lung cancer, where we are now today, and what is the next. So, can my slides be shared?
Yeah, sir, just sharing the slides.
Please go ahead, please.
So slides are visible.
Yeah. So, kindly move next slide. So, treatment options for patients with metastatic non-small cell lung cancer who don't have any actionable driver mutation. As in the previous speakers have already spoken well about drugs or molecules which are acting very good on non-small cell lung cancer or small cell lung cancer which have a driver mutations. But right away, if the non-small cell lung cancer is there and there is no acceptable or actionable driver mutation, the first line options are chemotherapy, Bev plus chemotherapy, chemoimmunomonotherapy, CIT plus chemotherapy, plus a combination of VEGF and immunotherapy plus chemo, a doublet plus chemotherapy. But once it progresses to second line, a drug which is not an option in later lines, if already given in the early lines. So options we have right to chemotherapy, bevacizumab, or anti-angiogenic treatment plus chemotherapy, or a monotherapy with the chemoimmunotherapy or with the checkpoint inhibitors. So only option if CIT is not used in first line, then only we can use it, or we can interchange the drugs or the molecules. Next slide, please. So the journey of atezolizumab and approvals in non-small lung cancer. It was approved in metastatic non-small lung cancer in 2016. In India, it was approved in 2017 at second line. First line approval was in 2019. Again, in a subset analysis, obviously we have approval based upon 3 trials, which I'll be later on speaking upon. First line non-small cell lung cancer in a metastatic setting in 2021 on the basis of IM power 130. Then on the basis of IM power 110, it got approved in 2021. And latest, it has been approved in adjuvant setting in 2022. And next possibly would be in adjuvant setting if it is approved. So right away, I'll be focusing my discussion on metastatic setting, and later on, the other speakers can take on over for the adjuvant setting also. Next slide, please. So now atezolizumab in first line metastatic non-small lung cancer. So based upon the phase 3 studies of atezolizumab in first line treatment of non-small lung cancer, we have 3 trials: Power 110, Power 130, and Power 150. So I'll be enumerating on these trials. The trial Power 110 had 572 patients with 2 arms, Arm A and Arm B. So in Arm A, it was monotherapy with atezolizumab, and in Arm B, it was a combination of a chemotherapy. Either it is a carbocyst plus pemetrexed, or it was a carbocisplatin plus gemcitabine in a squamous setting. And the approval was that is atezolizumab monotherapy a better agent than chemotherapy in PD-L1 selected chemotherapy naive patients. Similarly, in the Power 130, there were 2 arms. First arm A was atezolizumab plus nab-paclitaxel plus carboplatin, and in arm B was carboplatin plus nab-paclitaxel. And is steroid sparing chemotherapy regime a better combination partner for atezolizumab? And in Power 150, about 1,200 patients, there were 3 arms. Arm A was atezolizumab plus carboplatin plus paclitaxel. Arm B was atezolizumab plus carboplatin plus bevacizumab plus paclitaxel, and Arm C was a combination of bevacizumab plus paclicarb. So does the addition of atezolizumab to the standard of care, bevacizumab plus paclitaxel and carboplatin, adds to clinical benefit, or is there is improved clinical benefit if bevaci is replaced by atezolizumab? So I'll be discussing these trials one by one. Next slide, please. So coming to the first trial, IM Power 110, atezolizumab monotherapy versus chemotherapy in PD-L1 selected treatment patients, first line, stage 4 non-squamous or squamous non-small lung cancer, chemotherapy naive, PD-L1 selected, EGFR ALK negative. So it was stratified for sex, ECOG score, or performance data, histology, and PD-L1 IHC expression. About 572 patients. Primary endpoint was OS benefit in wild type population, which excluded already the patients with drivable mutations like EGFR ALK. And secondary endpoint was progression-free survival, overall response rate, and duration of response as per the RECIST criteria. So it was randomized in ratio of 1:1. In the arm A was atezolizumab 1200 milligram standard dose 3 weekly, followed by maintenance till progression or loss of clinical benefit. In arm B was non-squamous with carboplatin or cisplatin with pemetrexate, and in squamous histology it was gem-cis or gem-carb. And they were continued with pemetrexate in non-squamous histology or best supportive care in the squamous histology till progression. And there was no crossover permitted in the maintenance phase. Next slide, please. So coming to the primary endpoint of overall survival in TCS3 or ICS3 expression in subgroup, TCS3 is tumor cells with expression of more than 50%. ICS is immune cells with expression of more than 10% of PD-L1 by IHC. So you can very well see that median OS was improved by 7.51 months with atezolizumab over chemotherapy, and their median OS was about 13.1 months. So you can definitely see that the median OS was about 20.2 months in the arm of the monotherapy with atezolizumab vis-a-vis the red Kaplan-Meier curve, which is red one, and the hazard ratio was almost 0.59. So there was 40% reduction in the hazard in the atezolizumab monotherapy arm. So from this Kaplan-Meier curve, we can definitely say that there was almost 40% reduction in the progression or a death if we choose atezolizumab monotherapy versus a chemotherapy in a chemotherapy naive patients who has TCS3 or IC3 expression, that is more than 50% of expression of PD-L1 on tumor cells or more than 10% expression of PD-L1 on immune infiltrating cells. So that established the supremacy of atezolizumab monotherapy on the chemotherapy only on the basis of PD-L1. Next slide, please. And updated analysis, there was continued clinical meaningful improvement in progression to survival with atezolizumab maintenance versus chemotherapy. And you can very well say that the median PFS was about 5 months in the red arm, that is a chemotherapy maintenance arm, and or placebo arm, and the median PFS was about 8.2 months in the atezolizumab monotherapy, and the hazard ratio was almost 0.6. That was 40% reduction, and p-value was significant. It was less than 0.001. So PFS was not formally tested due to hierarchical testing plan. Next slide, please. And at the updated analysis of TCS3 or IC3 wild type population, overall response rate was improved at atezolizumab versus chemotherapy. You can see arm A, the response rate is about 42.2%, whereas in the chemotherapy arm, whether you are using paclitaxel or pemetrexate, the response rate was about 28.6%. So, and the median duration of response was almost better in the monotherapy arm. It was 38.9 months versus 8.3 months in the chemotherapy arm. So overall response rate as well as duration of response was better in the atezolizumab monotherapy arm. Next slide, please. Coming to the OS benefit. So OS benefit was maintained in PD-L1 high subgroup for atezolizumab over chemotherapy, and it was maintained. So you can very well see that in all the three subsets, the atezolizumab OS was on the left-hand side. You can see the median OS was about 20.2 months. In the middle arm, it was about 20.2 months, and in the right-hand extreme right-hand, where the TC is more than 50%, it was 19.5 months versus chemotherapy, which was 13.1 month, 11 month, and respectively 16.1 month. So OS benefit and PS benefit, both PFS benefit, both have been achieved with atezolizumab monotherapy arm in patient subset which have a high PD-L1 expression. Next slide, please. So the updated safety analysis was consistent with the data presented at primary analysis. So you can very well see that the side effect profile, we expect a subset of side effects which are better, will be more with the chemotherapy and which will be more with the use of IC agents. So you can see that the most important side effects were basically due to the autoimmunity, which were seen with the atezolizumab arm, and the chemotherapy arm was having the typical side effects which are related with the chemotherapy, but all were manageable. And you can see almost grade 3 to grade 4 adverse events for about 33% in the atezo arm, and it was almost 53% in the chemotherapy arm. So on the adverse event analysis also, atezo arm was better than the chemotherapy arm. Next slide, please. So coming to this bar diagram, you can very well see that the known adverse events which are known with the ICIs, especially with the atezo arm, are higher in the arm A, that is the asymptomatic rise of liver function, rash, nasopharyngitis, arthralgias, pruritus, hypothyroidism. And on the other hand, you can very well see that the chemotherapy arm were having the major side effects which are more frequent with the chemo, like anemia, nausea, neutropenia, constipation, thrombocytopenia, and low febrile neutropenia, low platelet, and leukopenia. Next slide, please. So let me summarize the trial IM Power 110. IM Power 110 is a positive study that demonstrated statistically significant and clinically meaningful improvement of OS in PD-L1 high subgroup wild type population versus platinum-based chemotherapy. Hazard ratio was about 0.59. That means you have 40% less chances of getting a hazard like progression-free or a death in a monotherapy arm with a atezo. And in the TC3 or IC3 wild type population, atezo showed meaningful improvement in progression-free survival, overall response rate, as well as duration of response versus chemotherapy. The safety profile of atezo was consistent with prior observations. No new or unexpected safety signals were identified. So this was a summary of IM Power 110, on the basis of which atezo monotherapy was given a approval for the second line treatment. Next line, please. So coming to the next trial, which was IM Power 130, it was a phase 3 study of carboplatin and nab-paclitaxel with or without atezo in first-line advanced non-squamous non-small lung cancer. Next slide. So trial design, like other randomized trials, the basic is non-squamous histology, stage 4 non-squamous non-small cell lung cancer, chemotherapy naive, performance status 0 to 1, stratification equal almost for the sex, PD-L1, IS6 expression, and presence of liver metastasis. Intent to treat population was about 723 patients, and out of which wild type were about 679 patients. So ratio was 2:1 randomization. In arm A, atezo was 1200 milligram per meter, every 3 weeks fixed dose. Nab-paclitaxel was 100 milligram day 1 at 15, 3-weekly. Carboplatin was AUC6 every 3 weeks, followed by maintenance atezo till progression of loss of clinical benefit. Arm B was nab-pacli plus carb 4 to 6 cycles in the same dosage, followed by pemetrexed or best supportive care, and followed by pemetrexed until progression of disease. Switch was possible because of the trial design, and it was permitted in the control arm. Next slide, please.
Sir, sorry to interrupt you. Please conclude your talk in next 2 minutes.
Okay. So in that case, I have to rush up through the slides. Next slide, please. Next slide. Next slide, please. So I'm just coming straight away to the PFS benefit. Next slide, please. I think you have not uploaded those slides which I have. Next slide, please. Yeah. So coming to the straight away. No, back. Go back. So coming to the PFS benefit, you can see a median PFS about 5.5 months in chemotherapy arm and 7 months in the atezo plus chemo arm. Next slide. So coming to the forest plot, you see that all the squares are on the left side. That means atezo is better as compared to placebo in the maintenance phase. Next slide, please. Coming to the OS benefit, OS was statistically significantly improved with the addition of atezolizumab to the CAR plus NAP arm. And you can very well see that on year 1, it was 63.1%, and in year 2, it was 40% almost, versus CAR plus NAP-ACLI arm 55.5 and 30 months. So hazard ratio was about 0.79, 20% less risk of death or progression with the atezo addition. Next slide, please. Coming to forest plot, again, this is showing better atezo. All the squares are on the left side, and it was in the intent to treat population. It was OS benefit across all the population, age, ECOG score, smoker, non-smoker liver mets or non-liver mets. Yes, little bit on the right side in the patients who had liver mets at the enrollment. Whether the PLD, PDL1 is high or low, it is helping in all the subsets. Next slide, please. Yeah. So let me summarize it. So IM power 130 met its co-primary progression-free survival and OS and points and demonstrated statistically significant and clinical meaningful benefit of about 4.7 months OS benefit, 1.5 months of progression-free survival for atezo plus chemo in intent to treat wild population compared to chemotherapy alone. OS and PS benefits observed in all the PDL subgroups. Atezo plus chemo had a safety profile consistent with adverse events associated with single agent treatment, that is more of autoimmune disorders. No new safety signals were identified. IM power 130 results and support atezo plus chemo as a treatment option for patients with advanced non-squamous non-small cell lung cancer. So this is summary of trial 2. Coming to the third trial, I'll be hurrying up. Next slide, please. So two more minutes. So third trial is IM power 150. It's a phase 3 study of atezo plus chemo and Bivasi. So combination of both anti-VEGF and IC agent in first line advanced non-small lung cancer, which is non-squamous. Next slide, please. So study design already have enumerated. Next slide. So basic characteristics are well balanced. Next slide. So this is important slide. Next slide. Yeah. So there is a significant OS benefit with addition of atezo in intent to treat wild type arms, whether arm B or C. You can very well see that median OS is almost 14.7 months in arm which is carrying Bev plus chemo. It is almost 19.5 months in atezo plus Bev arm plus chemo arm, and hazard ratio is 0.80. That means 20% more benefit of PFS as compared to and OS benefit as compared once you don't add atezo to the combination of anti-VEGF plus chemo. Next slide, please. So improvement is almost 4.5 months. Coming to the response rate and duration response, there you can very well see that it is across all the subset. It is better in arm which had atezo along with the combination that is Bev plus chemo vis-a-vis Bev plus chemo or chemo alone. Next slide, please. OS benefit, you can very well see that it is better in PDL1 high as compared to PDL low, but majority of patients who have the maximum benefit were PDL1 high patients. But it is across all the groups, especially hazard ratio is 0.7 for the high PDL1 group. Next slide, please. OS benefit was observed across all PDL1 subgroups in intent to treat wild population in arm B and C. Next slide. This is an important slide. What if you have concomitant driver mutations? So if we have subset analysis for EGFR positive, so intent to treat population about 1200 patients. IM power 150 patients. You can, let's go to next slide. So you can see again, even if you have a driver mutation, you have a meaningful progression-free survival benefit for arm B versus arm C in EGFR positive mutation or ALK positive non-small cell lung cancer patients. So initially they look like almost similar lines, but they started separating at 6 months, and this difference keep on maintaining till almost 20 months. So hazard ratio is 0.59, which is very significant. That means 40% less chances of progression or death if you have added atezo, even if you have a driver mutation along with that. So you are bombarding the patient cancer cells from all the sides, chemo, anti-VEGF, immunotherapy, and you're getting the maximum benefit punching out of that. Next slide, please. Again, you can see OS benefit also in arm B versus arm C. So median OS is 18.1 month in BEV plus chemo. Hazard ratio is 0.6 as compared to the patients who are having high this PDL1. But you cannot see hazard ratios 1. That is between arm A and arm C. That means you cannot get benefit if you don't have a driver mutation along with that. Next slide, please. OS benefit, again, you can see that it is more in patients who have a sensitizing EGFR mutation with prior TKI therapy versus those patients who are having EGFR without prior TKI therapy. Next slide, please. Next slide. So coming to liver metastasis, meaningful PFS was observed if arm B versus arm C in patients with liver metastasis at baseline. So you can see that almost 5.4 months median PFS was seen in the patient with liver metastasis. It was seen 8.2 months in the patient with liver metastasis, but who had a atezo along with that. Next slide, please. OS benefit again seen in patients with liver metastasis who had atezo added with that, but there was no OS benefit when it is compared with arm A and arm C. Next slide, please. Whether you had BEV or without BEV, if you have a liver metastasis. Response is better with addition of atezolizumab, 60.8 months versus 41.1 months. Next slide, please. Patient with bulky disease. Again, next slide. So you have seen efficacy of outcomes of high and low burden disease. So again, you see better OS and overall response rate with addition of atezo as compared to the BEV or without BEV. Next slide, please. Coming to the adverse events expected, as if you add both anti-VEGF as well as ICI like atezo, you will get a side effect profile of both. So but again, no new safety signals were identified with the combination, and the safety profiles of ABCP and ACP were similar to A and B and combination of chemo plus paclitaxel plus cisplatin. Next slide, please. So let me summarize this trial also, that atezo bevacizumab plus chemotherapy in non-squamous histology, it helps in all the PDL1, whether it is less than 1% or more than 1%. You get significant benefit in patients who has progressed on TKI, having liver metastasis, who have a bulky disease. Next slide, please. Next slide, please. So doing what next? So this is what I have enumerated already, that next will be adjuvant setting, and thereafter possibly be getting atezo with combination of BEV or without BEV in neoadjuvant setting. So with this, I will conclude my talk with this carrying home message that addition of atezo will help either as a monotherapy in second line, atezo with combination in first line, atezo plus driver mutation in first line. So you will get benefit across all the patients, whether they have a driver mutation, whether they have a bulky disease, whether they have a liver metastasis. Addition of atezo will help. I'm thankful for your patient hearing. I'll conclude my talk here. Thank you.
Thank you, Dr. Rajiv sir, for the exhaustive presentation. I think you have covered everything in so much detail. And due to shortage of time, I will like to skip the discussion and questioning part and will move forward to the next session. Thank you, sir.
Thank you, Dr. Mukesh.
So,
Okay.
Dhruv,
And before you proceed, I'm thankful to Roche also, who provided this academic material for this CME. Thank you and good night.
Dhruv, can you play the slides? Next we are
Yeah, I have shared the slides now.
Yeah, from the lung cancer, we are moving to the breast cancer. Again, I think you have opened the wrong slides. Please open the clinical insights in breast cancer with ASCO updates of 2025. Yeah, Dhruv. Yeah, so coming to the next. So a very interesting abstract was presented. Yeah, please be on the first slide. Dhruv. Dhruv, yeah. So sacituzumab govitecan plus pembrolizumab versus chemotherapy plus pembro in patients with previously untreated PDL1 positive advanced or metastatic TNBC. So these are the primary results from the randomized phase 3 ASCENT-04 keynote D19 study. Next slide. So chemo pembro versus sacituzumab govitecan pembro. Next. So there is an unmet need for better treatments in the first line setting for patients with PDL1 positive metastatic TNBC. Sacituzumab govitecan plus pembro led to a statistically significant and clinically meaningful improvement in PFS versus pembro plus chemotherapy. These results support SG plus pembro as a potential new first line standard of care. Next. So why there is an unmet need? So median PFS observed in prior studies of chemotherapy in combination with immune checkpoint inhibitors was somewhere between 7.5 to 10 months. Most patients still experience disease progression within first year. About half of the patients treated for first-line metastatic TNBC do not receive second-line treatments. The rationale for this study is SG is the only TROP2 directed ADC with demonstrated OS benefit in multiple phase 3 studies. It is approved for second-line metastatic TNBC and pre-treated hormone-positive HER2-negative MBC in multiple countries. Early studies have observed improved anti-tumor effects when immunotherapy is combined with ADC. So here we present the primary results from the global randomized phase 3 ASCENT keynote D19 study of SG plus pembro versus chemo plus pembro in previously untreated PDL1 positive, locally advanced, unresectable or metastatic TNBC. Next. Next slide. Yeah, the slides are not moving. Yeah, sure. So the study design, yeah, previous only, the study design. Dhruv, please play the previous slide only.
So slides are not moving over.
Yeah, please play the previous slide. You have gone to the next slide. Please play the previous slide. Yes. So PDL1 positivity, CPS more than or equal to 10 by the 22C3 assay, 6 or more months since treatment in curative setting where prior anti-PDL1 use was allowed. So 443 patients were there. 1:1 randomization, SG plus Pembro, SG 10 mg per kg IV on day 1 and 8 of 21-day cycle, plus Pembro on the standard dose of 200 mg, day 1 of 3-week cycle. 221 patients were there. 222 patients were there on chemo plus Pembro, where Pacli 90 mg per square meter or Nab-Pacli in the dose of 100 mg per square meter on day 1, 8 and 15 of 28-day cycle, or gemcitabine 1 gram per meter square plus carb with the AUC2 on day 1 and 8 of 21-day cycle with Pembro in the standard dose was used. So all treatments including SG or chemo was continued until Beaker verified disease progression or unacceptable toxicity. The endpoint was primary progression-free survival by Beaker analysis, and secondary endpoints were overall survival, overall response rate, duration of response, and safety and quality of data, quality of life. Next slide. So hierarchical testing procedures in the intention to treat population, PFS by Beaker, one-sided alpha 2.5%. If it is the descriptive OS nominal alpha spend, if PFS is positive, then continue to the overall survival. So this is the technical part, technical design of the trial, and the statistical design of the trial basically. Data cutoff date was primary PFS was 3rd March 2025. Median follow-up was for 14 months. as of the data cutoff, 43% patients in the SG plus Pembro and 23% in the chemo plus Pembro group continue to receive study treatment. Next. So PFS 11.2 months in the SG plus Pembro compared to 7.8 in the chemo plus Pembro, with the p-value that is significant and a stratified hazard ratio of 0.65. 12-month PFS rate is 48% in the SG plus Pembro versus 33% in the chemo plus Pembro group. So SG plus Pembro demonstrated statistically significant and clinically meaningful improvement in PFS compared to chemo plus Pembro, with a 35% reduction in risk of disease progression or death. Next slide. So PFS by investigator assessment 11.3 versus 8.3 months, hazard ratio 0.67, again a significant p-value. So it again demonstrates the consistent benefit with the Becker analysis. Next slide. Descriptive overall survival at primary analysis. OS data were immature. However, a positive trend in improvement was observed for SG plus Pembro versus chemo plus Pembro. 81% of patients who received any subsequent treatment after discontinuation of chemo plus Pembro received sacituzumab govitecan. So hazard ratio is 0.89 for the overall survival, favoring SG plus Pembro. Next slide. Tumor responses and duration of response by Becker. Median duration of response is 16.5 months in SG plus Pembro versus 9.2 months, leading to a benefit of more than 7 months. A substantially longer duration of response and a higher overall response rate, including an increased complete response rate, was observed for SG plus Pembro. Next slide. So exposure and safety summary. Treatment emergent side effects were there in 84% of the patients, in 38% of the patients in SG plus Pembro, compared to 31% in chemo plus Pembro. Treatment related worsenments leading to treatment discontinuation 26 versus 68. Dose interruptions were almost equal. Treatment leading to death, the is again almost equal, 7 and 6 patients in both the groups, out of which treatment related were in 3 in SG plus Pembro and 1 in chemo plus Pembro. So despite longer duration of treatment with SG plus Pembro, rates of grade 3 and 4 side effects were similar for both groups. Treatment related adverse events leading to dose reduction or treatment discontinuation were lower with SG plus Pembro. Next slide. Next, yeah. So to conclude, ASCENT-04 Keynote D19 is the first randomized phase 3 study to evaluate the efficacy and safety of an ADC checkpoint inhibitor combination for first-line treatment of patients with PDL positive metastatic TNBC. SG plus Pembro led to a statistically significant and clinically meaningful improvement in PFS versus chemo plus Pembro, 11.2 versus 7.8 months. PFS benefit was observed across all pre-specified subgroups. OS data are immature, but an early trend in improvement was observed. Overall response rate was higher and responses were more durable with SG plus Pembro. The safety profile of SG plus Pembro was consistent with the established profiles of other agent. No additive toxicity was observed. So results support the use of SG plus Pembro as a potential new standard of care for patients with previously untreated PDL1 positive, locally advanced, unresectable or metastatic TNBC. Next.
Thank you, sir. Thank you for the excellent presentation. And I think we have Rajiv Sani, sir, with us. So kindly invite them.
So yeah, I think so in the interest of time, I will wrap up that discussion. So we quickly move on to the next, and I welcome Dr. Rajiv Sani, who will be speaking on how I treat extensive stage small cell lung cancer with durvalumab, the real world experience. Dr. Rajiv Sani is Senior Consultant Medical Oncology at Shri Mata Vaishno Devi Narayana Super Specialty Hospital, Jammu. Over to you, Dr. Rajiv.
Thanks, Mukesh and AstraZeneca for giving me the opportunity to share a real-world experience regarding efficacy of durvalumab in small cell lung cancer, extensive disease. Can I have my slide, please?
Yeah, sir, just sharing your slides.
Yeah. So as all of us are aware of that small cell lung cancer, extensive disease is one of the diseases where the prognosis is very poor. Only I think less than 10% patient crosses 1 year after treatment with chemotherapy. For
The slides
very
are
longer.
visible.
Yeah, slides are visible. You can move the slides. So very few patient can cross 1 year in patient with extensive disease small cell lung cancer. So I'll discuss a case where the patient was treated with immuno plus chemotherapy has shown a durable survival benefit with the use of immunotherapy, which was earlier unheard of with chemotherapy. So this is case which is being provided by from the company sides. Mr. X, who is a 35-year-old gentleman, presented in June 2021 with a complaints of change in voice, which slowly progressed to aphonia with no comorbidities, and with a smoking history of around 400, that is 40 pack per year. And this patient with this history presented to ENT, and he was diagnosed with vocal cord palsy. He underwent CT scan of head, neck, chest, and brain. Next slide. So after presenting complaints, it take around 2 months to do his CT scan, because patient initially went to many doctors where initially he was treated for his vague symptoms with over-the-counter drugs. But after 2 months of his symptom and the symptom deteriorates, first CT scan was done in August 2021. So it shows a mild enhancing soft tissue with surrounding fibrosis in left apical segment, with multiple enlarged conglomerated necrotic lymph node in left hilar, paratracheal, and paraesophageal region. And also this nodes forming a nodal mass compressing left pulmonary artery. Next slide. So based on CT scan, the further work was not done, and patient was initially treated by a physician as a case of tuberculosis. He suspected as a case of tuberculosis and started on ATT. But however, after 1 month with the ATT, his condition worsened, and patient presented in an emergency department with a history of a seizure, and he was started on anti-epileptic drug. And follow-up MRI brain was done. Next slide. So the MRI showed a lesion in right temporal lobe with mild surrounding edema without appreciable mass effect. And there are multiple sub-centimeter size lesions seen in bilateral temporal and left frontal parieto-occipital lobes. Next slide. So patient suspected of malignancy, and then CT chest was done, which shows space-occupying lesion in left upper lobe with mediastinal extension and encasement of left pulmonary artery with mediastinal lymph nodes and consolidation in left upper lobe. Next slide. So then the PET scan was done. You can clearly see from the PET scan there was a large hilar mass with conglomerated lymph nodes. Next slide. Next slide, please. Yeah. So there are cervical lymph node also. There are apical paratracheal lymph node also. And you can see on the right side of this slide, there was a brain lesion also is present at that time. So with this scenario, keeping in mind the diagnosis of malignancy was suspected, and biopsy was done, which turned out to be small cell histology of lung carcinoma. Next slide. So ultimately, after around 4 months from the initial symptom, patient was finally labeled as extensive stage small cell lung carcinoma with brain metastasis. Next slide. So as we have very well aware that when the patient of small cell lung cancer presented to us with brain metastasis, the question is whether we should start with the systemic therapy first or brain radiotherapy. Though the answer for this question is being given by many trials, where if it was concluded that if the patient is symptomatic for brain lesion, then the brain radiotherapy should be started, followed by cystic therapy. However, if the patient need urgent chemotherapy, urgent treatment, then the chemotherapy can be started first, followed by and immediately followed by radiotherapy. Next slide. So this is a paper where by the European expert, and they have the key conclusion of this paper is that in asymptomatic patient with brain mets, chemotherapy alone is the most commonly recommended first-line treatment. However, if asymptomatic patient has limited volume brain metastasis, a higher preference for chemotherapy without WBRT is considered. But if the patient is symptomatic, then upfront WBRT followed by chemotherapy was recommended most commonly. But even the patient was symptomatic, and if there are limited number of mets in brain, we can always give as BRT, and then we can start chemotherapy immediately. Next slide. This is being also accepted by the NCCN guideline also. Next slide. So now coming to the chemotherapy in extensive stage small cell lung cancer. From last many decades, etoposide and platinum-based chemotherapy is standard for patient of extensive stage small cell lung cancer. Various regimes were compared against etoposide and platinum, and none of the regime was found to be superior to this regime. And you can clearly see that response rate with this regime goes around 50 to 70%, and median overall survival is around from 8 months to 10 months. Next slide. Coming to our patient, the patient was started with chemotherapy, that is etoposide and cisplatin, and after giving 3 days of chemotherapy, patient was started on radiation therapy, where 30 gray of radiation therapy in 10 fraction was given to whole brain with hippocampal sparing, followed by 9 gray in 3 fraction to gross lesion. Next slide. Next slide. Yeah. So 4-5 years back, if we see 5-6 years back, all patients were treated with etoposide and platinum-based chemotherapy, and it is considered as a category 1. But now, after seeing that chemotherapy, previous slide, please go to previous. Yeah. So after the approval of atezolizumab and durvalumab in the existing regime of etoposide and platinum-based chemotherapy, now it becomes the category 1 and present standard of care. Next slide. Please go to next slide. So, and now a thought about consolidation thoracic artery. Those patients where there was a residual thoracic disease without extra thoracic disease, in that case, consolidation artery to thorax is considered, and it has shown survival benefit also. Coming to our patient, after completion of 3 cycle of chemotherapy, durvalumab was added to the chemotherapy at the dose of 1500 milligram every month. Next slide. So what are the rationale of adding checkpoint inhibitor with the chemotherapy in small cell lung cancer? You can clearly see that chemotherapy induced tumor cell killing, which induced tumor antigen release and exposure to the immune system. However, in spite of so much exposure to immune tumor cell antigens, this response, that is immune response, is suppressed by tumor cell due to overexpression of PD-L1, because PD-L1 interact with the PD-1 receptor on the tumor cells, which result into the suppression of immune T cell response and leading to T cell inhibitions. By targeting this axis, that is PD-L1 PD-1, with the use of PD-L1 inhibitor, this tumor specific T cell immunity was restored, and leading to the reversal of immune suppression, which lead to deeper and more durable systemic anti-tumor response. And because there is a high mutation burden of small cell lung cancer, which allow this tumor to be susceptible to immunotherapy. And the timing of immunotherapy in relation to other therapy, in particular chemotherapy, is critical to allowing disease control and the development of an immune response. Next slide. So the Caspian is the trial which has established the role of durvalumab in this subset of patients. It is the only approved immunotherapy regime in extensive stage small cell lung cancer, which allow 6 cycle of chemotherapy in control arm, and it allow a use of cisplatin or carboplatin. In this trial, newly diagnosed extensive stage small cell lung cancer were included, where they are randomized between chemotherapy plus durvalumab followed by durvalumab maintenance. And in this study, the primary endpoint was overall survival, and key secondary endpoint was PFS, OS at 18 months, health rated quality of life, overall response rate, PFS at 6 and 12 months. Next slide. And there is another drug which is atezolizumab, which was approved in this indication also. So there are some specific difference between the two trial designs. In the inclusion criteria in the Caspian are much more reflective of real world clinical practice as compared to IMPAVR, that atezolizumab trial, because this trial allowed the inclusion of untreated brain metastasis. It also allowed PCI to be allowed in experimental arm, as PCI is shown to have a survival benefit. And also it allows 6 cycle of chemotherapy in control arm. It allowed both carboplatin and cisplatin as compared to IMPAVR studies. So the inclusion criteria is much more reflective of real world clinical practices. Next slide. Next slide.
Sir, sorry to interrupt you. Please conclude your talk in next 2 minutes.
Sure, sure. Please go to the previous slide. Next slide. So the salient aspect of this trial is that durvalumab was given with immunotherapy for 3 weekly for 4 cycles, then every 4 weekly until disease progression. Choice of platinum, you can use cisplatin or carboplatin. OS is the final primary endpoint, and the control arm, in control arm, you can receive 6 cycle of platinum etoposide, which is in line with the real world practices. PCI was optional and is offered only in the control arm, not in the experimental arm, so which shows the much more benefit of that immunotherapy as compared to chemotherapy. And asymptomatic as well as treated and stable brain metastasis patients were included. Next slide. So this you can clearly see that after 6 months there was clear separation of the graph, and there was persistent benefit which was maintained. You can clearly see that at 6 months the PFS percentage was same, but after 6 months, that is on 12 months, 18 months, 20 months, there was drastic difference between the PFS benefit between the two arms. Next slide. So the majority of patients who are progression free at 1 year, they remain progression free even after 2 years. Regarding the OS also, the median OS in the durvalumab arm is around 13 months, while in chemotherapy alone arm is around 10.5 months with a hazard ratio of 0.71. And 3 times more patients were alive in durvalumab arm at 3 years as compared to chemotherapy alone arm. Next slide. And if we see the subgroup analysis also, all the subgroup, irrespective of the brain mets, irrespective of the race, religion, performance status, were benefited with the use of durvalumab. Next slide. Regarding overall response rate also, there was 68% patient who responded as compared to 58%, and the duration of and the depth of response was maintained in the immunotherapy arm. Next slide. As I have told that in patients who are brain metastasis or without brain metastasis, all the patients were benefited with the use of addition of immunotherapy. Next slide. So coming back to our patient, the patient till January 2022, patient received chemotherapy, 3 cycle of chemotherapy and 3 cycle of immunotherapy. Next slide. And you can clearly see from the.
Sir would like you to conclude your
presentation. Just I want to conclude.
Thank you.
You can clearly see from this graph that there was the complete remission of the disease. Next slide. Both in the systemic as well as in the brain. And till April 2022, patient had received 6 cycle of chemotherapy, which was stopped at that time, and the immunotherapy was continued thereafter once in a month. Next slide. Next slide. So to conclude my talk, the patient shows durable response for longer period of time. In fact, I have one patient who has in complete remission from last 3 years with the durvalumab in extensive stage small cell lung cancer. Next slide. Next slide. Next slide. So the first line durvalumab and chemotherapy has shown sustained improvement in OS compared with the chemotherapy alone. And durvalumab is the only IO that provides flexibility of choosing platinum. Benefit with the durvalumab is seen across all subgroups, including brain metastasis. More than 70% of patients in durvalumab arm are surviving even after 3 years of showing prolonged survival benefit. And it offers convenient once monthly dosing regime in the maintenance phase. Thank you.
Thank you, Dr. Rajiv, for the nice presentation. So quickly moving to the next session, I invite Dr. Deepak Bharti, who is Senior Consultant Medical Oncology at Narayana Hospital, Katara, Jammu. He will be discussing the role of anti-EGFR in the era of immunotherapy in head and neck cancer. I request Dr. Deepak to be fast in his presentation in the interest of time. Yeah. Over to you, Dr. Deepak.
I'm sharing. Mr. Dhruv, I am sharing the screen.
Yeah, you can share your screen.
So my slides are visible.
Yes, they are, sir.
Okay. So good evening, everyone. So keeping the time into consideration. So point is that basically the topic of discussion today is that we know regarding head and neck cancers, we are all about chemotherapy, immunotherapy, but there's one molecule which is there in the literature and all the way around for the last 5-6 years and has been established by Tata Memorial trial and all one to more trials were, and also in the ASCO 2024 the role of it has been proven. But we will just discuss and rewrap and revise that where it can still be used and we are not using and not giving benefit to our patients in one day-to-day practice. So regarding locally advanced squamous cell carcinoma head and neck, we know whenever patient comes from stage 2 up to stage 4A and which are not resectable or something like that, we are offering chemoradiation therapy is still the core treatment option for these patients, and these are the all trials are there. And going for the first and last, we are routinely using cisplatin weekly or cisplatin 3 weekly. And just I want to highlight that in 3 weekly it has 19-month PFS, and in weekly it is 24 months. So rest we are not using routine day-to-day practice. Okay, so these are certain trials where there's a role of chemotherapy addition will be there, and it all the trials have shown that whenever we add chemotherapy in locally advanced squamous cell carcinoma, obviously the benefit is there to the tune of 10 to 20%. The first one from 40 to 53, 30% benefit, from 57 to 65, 8% benefit. So these all other factors are there which are shown that good quantum of benefit shown by addition of chemotherapy in these patients, although it's work as a sensitizing agent for the radiotherapy. So one more meta-analysis are there. Good number of touching 20,000 patients they have included in the trial, and all the things they have shown that we have to add chemotherapy in the non-metastatic stage 3 or 4. By 4 it means stage 4A. Okay, so we know from all the wings that likely hypopharynx and larynx, and in certain oropharynx cancers also, certain patients which are not initially amenable to radiation therapy, we are giving using induction chemotherapy in the form of DCF or doublet agent also, so that we can decrease the bulk size of the disease, and then we can put the patient of CRT or radiation therapy. Although certain parameters of addition of EGFR targeted role is there in these patients, and what these role are and how we can use that we will discuss in our future slides. And regarding the role of immunotherapy, although it's evolved in the stage 4 setting only, but there are certain trials which have underwent which have shown that if we add immunotherapy in the CTRT setting, what response they can show us. Although till now all other failed trials, but certain trials from phase 1 and phase 2 still going on, and we have to wait for the results for them. Okay, regarding the immunotherapy, these are the list of trials and list of drugs which are going on. All are phase 1 and phase 2 only, and mostly settings are stage 4 recurrent and metastatic setting. And there are one trial which I want to highlight in the second last. If you want to see, this is addition of durvalumab. It is in the form of phase 1B, and it is basically before surgery. It is NSCT setting where there's a role of immunotherapy. They have put it. We have to wait for the result to go on. So these all are the such are going on in the head and neck squamous cancer in with the use of immunotherapy. So there's one trial where they have used immuno in the form of pembro with CRT versus CRT alone. So they want basically they use oropharynx, pharynx, and larynx patient. There's no oral cavity patient in their trial. And how they formulate the thing, I just want to highlight one point. This is a failed trial, both statistically. Although superiority has been shown towards pembro, but they have failed to meet the superiority threshold. So overall, till now, pembro plus CRT is a failed trial proved by Keynote 412. There's a one more trial, although it's phase 1B. It's not good to discuss this data, but obviously the time and mature, and we will transfer from phase 2 to phase 3. Although small number of 59 patients are there, and we know there's a segregation of HPV group is there. What is the importance of that? Is basically prognostic marker. We know the patient with HPV positive one are bound to get more benefit with chemotherapy, radiotherapy, and immunotherapy also, and they are the one which are have a good prognosis as compared to an HPV negative group. So what this phase 1 trial has shown that in the HPV positive group, just see the PFS after 2 years, touching 92.8%. And if the same trial, same group, but different HPV negative group, it is 49%. So touching 42% less benefit shown by negative group as compared to positive group. So this way it has shown that HPV positivity is a good prognosis marker, and we have to follow that. And similarly, like chemo and radiotherapy, immunotherapy also play a part with HPV positive group. Okay, so then come the role of this OS benefit also is also part of the same. On the initial trial which I discussed, it is a failed trial. This is another trial which is going on, and this is data of phase 1B trial only. Okay, so moving the third topic from chemotherapy to immunotherapy to the what we are topic of discussion is the EGFR expression. We know among all the body sites where there is a role of tumor sites, and EGFR expression is the lot more seen in the head and neck cancers. And we want to highlight this topic that how we can use this target and whether it is a lead to poor survival or we can still improve whosoever getting the EGFR expression. So initially when they started the thing, they want to treat differently. They want to add CRT with panitumumab, alutinib, lapatinib, and stuximab. But all the trials are failed trial, active trials. A reason we don't know what has happened with the use of EGFR inhibitor. And keeping this thing in consideration, lot of studies are still going on, and among them there's a one molecule which I'm highlighting, that is the third one, nemotuzumab, which they have used in combination CRT. Although they have used in stage 3 and 4 only, the point of discussion is that the patients who have a heavy burden bulky disease, especially N2 and 3, I think these are a subgroup where we are still add nemotuzumab in combination with chemo and radiotherapy, because the even after giving CRT, we are not able to get the maximum overall response rates, and we are still left with some residual disease. And for these patients to overcome, we have to treat the relapse setting, and we have to treat with the metastatic setting only after 3, 4, or 6 months only. So why not to give a benefit of doubt? If someone has good PS, we should add nemotuzumab to that subgroup, and I think this will change the scenario of and giving more benefit to our survival to our patients. And for this thing to happen, I have some database to discuss. So just I want to discuss from all the which I've concluded. So keep apart the mitomycin and carbo. Just want to see the last 4 points. It is the cisplatin plus CRT. It is 18 months. It's not about the 18 months what is EOS. It is a survival benefit what they have found. Apart from all the other things, 18 months more survival evidence shown by cisplatin group, 19% by stuximab group, biomab, which means nemotuzumab, it is 45 months. And if you want to add biomab plus chemo plus radiation, it is more than 60 months. So touching 5-year more median survival evidence shown by this group. And I'm not saying that you have to use this drug from here and there, but they are set as specific indication, especially for the good PS patients and with heavy burden of disease. So this is a trial which I'm talking about is all from the Indian settings, organized by Mr. Reddy, and it's a Kidway from Kidway Center. And I just want to highlight these two things. They have added the trial, the name of best trial. With nemotuzumab, there's a 100% efficacy rate or overall response rate after 6 months. It's not a thing. Either we are going with after 3 or 6 months, we are valued the patient after CRT. But this way, they want to assess up to 6 months. Up to 6 months, they have found that 100% patients have a overall response rates versus 70% who are not
So I
using
would
nemotuzumab.
request you to conclude your presentation.
Okay, no problem. Okay, and then after that, RT group is 76 versus 37%. So this way, the data they have shown that it is the 57% versus 26%, 30% more benefit shown by the nemotuzumab group. So the patient who are not cisplatin eligible, there are a group they will definitely we have to add the nemotuzumab. Okay, this is another trial which I'm from Tata, Kumar Prabhash. Obviously, similar group, all the subset they have included up CRT versus CRT plus nimotuzumab, and they have want to show that after 2 year PFS is 50 and 48, touching 10 to 12% benefit from all the subgroups. Regarding OS, I want to say 6% benefit with the addition of nimotuzumab group. These are all the trials are there which have shown that nothing can be done good from addition of stuximab. One more meta-analysis which has shown that stuximab as a failed trial as anti-EGFR in head and neck, and all other things with cisplatin and carbon stuximab all are still not able to achieve what results has been achieved by nimotuzumab till now in head and neck setting. And in other way around, cisplatin is still fare better than as compared to carboplatin and stuximab. Some pembrolizumab trials. This is not a topic of discussion in the present scenario, but I still want to help you that pembrolizumab is also a failed trial which have not shown any significant in local regional overall or PFS benefit. So these are trials are still undergoing. So there's no prime time yet for immunotherapy in localized head and neck center till now. These are ASCO 24 data published by for nimotuzumab. What they have shown that in the phase 3 trial, more than this nimotuzumab plus CRT versus so all the things are there from Kidway, from Tata, and from ASCO, which are shown that touching 10%. And if you want last line median OS is 1.8 versus 2.4, touching 1 year more benefit has been shown by nimotuzumab group. Thanks a lot.
Thank you, Dr. Deepak, for the quick presentation. I think nimotuzumab, as you have discussed, has definitely a role to play in head and neck cancer, especially we select our patients carefully. Not all patients are to be put on the immunotherapy. I think that's the message you have conveyed in your presentation.
Yes, yes.
Thank you. Moving on to the next session, I invite Dr. Priyanshu Chaudhary, Senior Consultant Medical Oncology, Levasa Hospital, Mohali, for the last session of the day.
Thank you, Dr. Mukesh. Please let me share my slides. This session is sponsored by Zydus, and the slides have been provided to me by Zydus. So dual HER2 blockade changing the way of breast cancer management in India. So breast cancer, as we all know, the incidence is rising fast. Latest data show around 2.32 lakh new cases of breast cancer in India. So among the female, it surpasses every other cancer. I mean, it has more incidence than the next four combined. Approximately 20-25% of breast cancer patients have tumor that are HER2 positive. So we'll be discussing the present and the future landscape. So first of all, we'll be discussing the neoadjuvant therapies. So which patients should be considered for neoadjuvant therapy? So basically, these are the surgical indications and high tumor volume to breast ratio, lymph node positive disease, high risk feature, high grade hormone receptor negative, HER2 positive, or TNBC, younger age at diagnosis. So for HER2 positive disease, tumor more than 2 centimeter, that is T2 or node positive, should receive neoadjuvant chemotherapy with trastuzumab plus pertuzumab. So if we look at the present landscape, what are the studies which we have for neoadjuvant therapies? We have the Neosphere and the Trifina, which were two studies which we discuss commonly when we talk about the dual HER2 blockade and neoadjuvant setting. So Neosphere was a study of neoadjuvant HER2 plus trastuzumab 4 cycles before surgery, followed by FEC, and the primary endpoint was PATH-CR in the intention to treat population. While the Trifina was basically a cardiac safety study, which included FEC followed by dual HER2 blockade plus dual HER2 blockade, as well as the PTH arm versus FEC plus PTH arm followed by PTH arm and PTCH. So we look at the results. The PATH-CR rates were significantly prolonged, significantly